At AA is home library list settings. X. Congenital anomalies of the kidneys. Congenital anomalies of the kidneys and urinary tract, KCUT, are one of the most common malformations diagnosed in newborns. The pathogenesis of KCUT is multifactorial, both specific genes and environmental factors, example in utero exposure to ACE inhibitors, have been implicated in the development of KCUT. Even though most cases are initially asymptomatic, up to 50% of children with end-stage renal disease have an underlying KCUT. For this reason, early identification of these malformations is essential in order to prevent renal damage. OFOT. Overview. Anomalies of the collecting system. Cent duplex collecting system, a complete or incomplete duplication of the collecting system, pelvic calyceal system and ureter, has different clinical manifestations depending on the degree of fusion. The most common congenital anomaly of the urinary tract. Complete duplication, an additional ureteric bud forms resulting in two separate ureteric buds that interact with the same metanephric blastema. The affected kidney has two separate pelvic calyceal systems and two ureters that enter the bladder at different points, double ureter. Copyright incomplete duplication, the ureteric bud splits before interacting with the metanephric blastema. The affected kidney has two collecting systems that merge between the ureteropelvic junction and the urinary bladder, resulting in a single ostium in the bladder equals bifid ureter. The affected kidney has two separate pelvic calyceal systems and two ureters that merge and share a single ostium into the bladder, Y-shaped ureter. Equals bifid pelvis. The affected kidney has two separate pelvic calyceal systems that merge into a single ureter at the ureteropelvic junction. Copyright associated with vesicoureteral reflux, ureteral stricture, hydronephrosis, and UTI. Ureteroureteral reflux may occur due to Y-shaped ureter. Cent ectopic ureter, the ureter opening is located caudal to the normal insertion site on the bladder. Copyright prenatal hydronephrosis. 1. Postnatal UTI. Copyright in female individuals, the ureter may bypass the external sphincter and insert directly in the vagina, resulting in incontinence. Ureterocele, abnormal dilation of the terminal portion of the ureter, which bulges into the urinary bladder or extends to the bladder neck and the urethra, often appears balloon-shaped on cystoscopy. Prenatal hydronephrosis. Copyright postnatal UTI. Ureteropelvic junction obstruction, see article on urinary tract obstruction. Malformation of the renal parenchyma. Renal dysgenesis. Renal agenesis, the absence of the kidney and the ureter. Copyright pathophysiology, ureteric bud does not develop. Complete lack of stimulating signals for differentiation of metanephric blastema. Kidney fails to develop. Copyright unilateral renal agenesis, usually asymptomatic, depending on the condition of the other kidney. See congenital solitary kidney. Bilateral renal agenesis, causes Potter sequence cent renal hypoplasia, underdevelopment of the kidney characterized by a reduced number of nephrons. Renal dysplasia, abnormal development of the kidney that results in a non-functional kidney with abnormal features, example cysts, increased amount of connective tissue. Copyright pathophysiology, ureteric bud does not properly stimulate differentiation of metanephric blastema. Disorganized nephrons, reduced number of nephrons, and abnormal cells. Unilateral dysplasia is usually asymptomatic. See congenital solitary kidney. Copyright bilateral dysplasia leads to early renal insufficiency and Potter sequence if present in utero. Examples: polycystic kidney disease, multicystic dysplastic kidneys, obstructive cystic dysplasia, medullary sponge kidney. Copyright associated with anomalies of the collecting system that predispose to UTI. Renal aplasia, kidney with only rudimentary renal parenchyma present with no residual function. Congenital solitary kidney. Cent definition, the presence of a single functioning kidney due to absence or anomalies of the contralateral kidney. Anatomical congenital solitary kidney, the absence of one kidney due to renal agenesis. Copyright functional congenital solitary kidney, a non-functional kidney due to example renal aplasia, severe renal dysplasia or hypoplasia often asymptomatic and diagnosed during prenatal ultrasound screening equals QL. Collapse fine text outline. X congenital anomalies of the kidneys. Scent often asymptomatic and diagnosed during prenatal ultrasound screening. Scent a solitary kidney is usually hypertrophic to compensate for the contralateral kidney. Scent higher incidence of anomalies, example vesicoureteral reflux, increased risk of hypertension, renal insufficiency, and progression to end-stage renal disease, anomalies of kidney migration. Scent horseshoe kidney, fusion of the left and right inferior renal poles *O normal ascent interrupted as fused kidney gets caught on the inferior mesenteric artery, IMA. Copyright increased incidence in patients with chromosomal aneuploidy, example trisomies 13, 18, 21, and Turner syndrome, O usually asymptomatic, typically diagnosed incidentally on abdominal imaging for unrelated conditions. O rarely requires treatment. O increased risk of renal stones, ureteropelvic junction obstruction, hydronephrosis, infections, and renal cancer. Scent renal dystopia and renal ectopia, displacement of the kidney within the retroperitoneum. Scent cross dystopia, displacement of the kidneys, both kidneys located on the same side of the spine. Malrotation, torsion of the orthotopic kidney. Etiology. Scent disturbance of embryonic development. Scent environmental factors. Scent in utero exposure to ACE inhibitors or angiotensin II receptor blockers. Juxtaglomerular hyperplasia, absent proximal convoluted tubules, or renal fibrosis. References. VA. OFO. Clinical features. Most K-cut are incidental findings with no clinical significance. K-cut are considered clinically significant if they can lead to chronic kidney disease, vesicoureteral reflux, urinary tract infections, hydronephrosis, or urinary incontinence. Signs that an underlying clinically significant K-cut may be present include, hydronephrosis on prenatal ultrasound. Copyright urinary tract infection in children. OFU. Diagnostics. Scent ultrasound imaging of the kidneys and bladder. First-line imaging modality. Copyright detects anatomical abnormalities. Copyright renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. AA. Collapse fine text outline. And diagnostics. Ultrasound imaging of the kidneys and bladder. Copyright first-line imaging modality. Detects anatomical abnormalities. Copyright renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. References to WAEY. As differential diagnoses. Floating kidney. Scent description. Downward displacement of the kidney due to reduced perirenal fat, thin individuals, anorexia nervosa, hypermobility of the kidney. Scent clinical features. Copyright flank and lower abdominal pain with exacerbation in upright position, nephroptosis causes painful strain. Copyright alleviation of pain in supine position. Diagnostics. Copyright renal ultrasound in upright and supine position. Degree intravenous pyelogram in upright and supine position. Scent treatment. Copyright conservative, abdominal muscle training and stabilization with abdominal wall binders. Copyright surgical, laparoscopic nephropexy, References. The differential diagnoses listed here are not exhaustive. VV, OE. Treatment. The majority of cases do not require treatment. If there is vesicoureteral reflux, administer antibiotic prophylaxis, see vesicoureteral reflux. If there is vesicoureteral reflux with recurrent cystitis or pyelonephritis, perform surgical correction. Abnormalities of the ureter or its insertion into the bladder, example ureterocele, ectopic ureter, are treated with resection of the distal ureter followed by ureteral reimplantation. Laparoscopic nephrectomy may be indicated in cases with recurrent pyelonephritis and loss of kidney function. WY. Sources. Last updated March 23, 2022. AQ al. Collapse fine text outline. And congenital anomalies of the kidneys, 1/6. / pelvis, /2 ureteral at orifices. Duplex collecting systems copyright Boss. Congenital anomalies of the kidneys, 2/6. Overlay. Horseshoe kidney with hydronephrosis VV. Intravenous pyelogram and scintigraph 35-year-old patient with recurring urinary tract infections, horseshoe morphology of the kidney, red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis, green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source, copyright IMPP. Urocongenital anomalies of the kidneys, 2/6. Knock-Mixture. Overlay. Horseshoe kidney with hydronephrosis VV intravenous pyelogram and scintigraph 35-year-old patient with recurring urinary tract infections, horseshoe morphology of the kidney, red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis, green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source, copyright IMPP. Overlay. Horseshoe kidney VV. Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source, Huefeasonier 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Copyright overlay. Horseshoe kidney VV Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source, Huefeasonier 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Congenital anomalies of the kidneys, 4/6. Overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source, Huefeasonier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Congenital anomalies of the kidneys, 4/6. Copyright overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source, Huefeasonier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Aorta celiac trunk superior mesenteric artery renal artery horseshoe kidney inferior mesenteric artery. Horseshoe kidney VV congenital abnormality of the kidney. Ventral view. Copyright Boss. Urocongenital anomalies of the kidneys, 6/6. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. C. With contrast, source, Hyophysenaire CT axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital anomalies of the kidneys, 6/6. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. C. With contrast, source, Hyophysenaire CT axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital anomalies of the kidneys, 1/1. Copyright. Overlay. Abdomen and pelvis VV. CT abdomen and pelvis, coronal view, H, esophagus, 1, spleen, 2, left kidney, 3, bowel, 4, psoas muscle, 5, right kidney, 6, liver. No pathologic features are noted. Source, copyright IMPP. X. Polycystic kidney disease. Polycystic kidney disease, PKD, is an inherited disorder characterized by the development of multiple cysts in the kidneys. It is classified into two distinct disorders, autosomal recessive PKD, ARPKD, and autosomal dominant PKD, ADPKD. ARPKD manifests with severe pulmonary insufficiency and progressive renal failure with onset during infancy or early childhood. If left untreated, ARPKD is typically lethal before adolescence. ADPKD manifests with flank pain, arterial hypertension, and progressive kidney disease with onset in adulthood. Early diagnosis and treatment may prevent or delay end-stage renal disease in both conditions, but kidney transplantation is the only curative treatment option. WAVZ. OESS. Epidemiology. Cent incidence ADPKD, 1/1,000. Equals the most common inherited cause of chronic kidney disease, 2, equals responsible for 5 to 10% of end-stage renal disease, ESRD, 3-degree ARPKD, 1/20,00041. Cent prevalence, 140,000 patients with polycystic kidney disease in the US. 5 plus sex, W equals 9. Epidemiological data refers to the US, unless otherwise specified. OOOE. Etiology. Plus ADPKD, 71 O autosomal dominant inheritance EO complete penetrance but variable expressivity copyright mutation in, LL9 equals PKD1 on chromosome 16, 85% of cases, the gene that encodes polycystin 1 or equals PKD2 on chromosome 4, 15% of cases, the gene that encodes polycystin 2 copyright positive family history 2-1E ARPKD O autosomal recessive inheritance copyright mutation in PKHD1 gene on chromosome 6, the gene that encodes for fibrocystin, a protein involved in the maintenance of primary cilia of the renal collecting duct and biliary epithelial cells. OECE. Pathophysiology. ADPKD. Cent 2 hit hypothesis copyright inherited mutation in one allele of PKD1, polycystin 1, or PKD2, polycystin 2, genes, 10 equals polycystin 1, involved in cell-cell and/or cell matrix interactions equals polycystin 2, a non-selective cation channel transporting Ca2*. Copyright additional second somatic acquired mutation in tubule epithelial cells sent abnormal cilia-mediated signaling pathways formation and expansion of cysts in the renal cortex and medulla compression of renal vessels with activation of the renin-angiotensin-aldosterone system, RAAS, ischemia, and destruction of the kidney parenchyma. 11 ARPCADE. Sent inherited mutation in the PKHD1 gene defective fibrocystin, also called polyductin, cystic dilation of collecting ducts and bile ducts, intrahepatic and extrahepatic bile ducts, 121. 7. Back collapse. Find text outline. Clinical features. ADPCADE. Sent symptom onset. Symptoms usually occur after 30 years of age, but the disease may also manifest during childhood. FLO symptoms are less severe and tend to manifest later in individuals with the PKD2 mutation compared to those with the PKD1 mutation. 13 Sent renal manifestations. Gross hematuria. Flank or abdominal pain. Recurrent urinary tract infections. Copyright nephrolithiasis. Kidneys might be palpable and enlarged on abdominal exam. They are usually normal at birth. Copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia, extrarenal manifestations, multiple benign hepatic cysts, prevalence increases with age. Copyright cysts may also occur in the pancreas, spleen, ovary, and testicles. 10 Cerebral berry aneurysm, 8%, 41. The risk is higher in patients with a family history positive of ADPCADE. May rupture and cause subarachnoid hemorrhage. The risk for growth and rupture is the same in patients with ADPCADE as in the general population. Copyright cardiovascular. Signs of arterial hypertension, example morning headaches, through increased renin production. Heart valve defects, particularly mitral valve prolapse. Left ventricular hypertrophy. Potential association with coronary artery aneurysm and aortic aneurysm. Copyright diverticula, diverticulosis, abdominal or inguinal hernias. RAN-IE+. ARPCADE. Symptom onset. Symptoms most commonly manifest in infancy or childhood. Sent renal manifestations. Protruding abdomen, non-tender abdominal mass, due to bilateral renal enlargement and / or hepatomegaly. Copyright chronic renal failure, frequently hematuria, proteinuria, and oliguria. Severe in utero renal impairment. Oliguria in utero. Maternal oligohydramnios. Potter sequence. Craniofacial abnormalities, retrognathia, low-set ears, flat nose, and clubbed feet. 1 Pulmonary hypoplasia. Respiratory insufficiency in neonates. Extrarenal manifestation. Hypertension, early manifestation. 4 often not responsive to monotherapy. Can result in complications if inadequately controlled, example cardiac hypertrophy, heart failure, cerebrovascular diseases, progressive renal impairment. Copyright liver involvement, congenital hepatic and portal fibrosis. Progressive liver failure and portal hypertension. ORET. Diagnostics. Imaging. Ultrasound. 5 ADPCADE. In adults, enlarged kidneys with multiple cysts bilaterally of varying sizes, anechoic masses. In children, evidence of cysts in combination with a family history positive of ADPCADE. Hepatic, pancreatic, and / or splenic cysts may be visible. ARPCADE. Enlarged kidneys with multiple cysts bilaterally of equal size. Diffuse increased echogenicity, despite the presence of liquid-filled cysts. Anechoic, hepatic cysts. Hepatic and portal fibrosis. CT5 not the method of choice. Back collapse. Find text outline. Sent CT not the method of choice. Copyright should only be used if ultrasound findings are unclear, due to the radiation exposure of CT. shows multiple cysts, usually hypodense, well demarcated, not septated, and thin-walled. Bilateral enlargement of the kidneys. Mr. Angiography, Screening for berry aneurysms in patients with ADPKD is recommended in the following scenarios. 16. Copyright family history of aneurysm. Copyright prior to extensive elective surgeries, example transplantation. Copyright occupations in which unconsciousness represents a public safety risk, example driver. Copyright the patient wishes to be screened. Further diagnostic tests. Scent genetic testing, DNA linkage analysis to identify ADPKD1 and ADPKD2, often not necessary. 9. Laboratory measures, to evaluate and monitor renal function. O blood cell count, can show renal anemia. Copyright creatinine clearance. O urinalysis, can show proteinuria, hematuria. E. Diagnostic laparoscopy and liver biopsy, in ambiguous cases. Pathology. Scent ADPKD-O progressive cystic dilatation of the kidney tubular system. Copyright cystic dilation in other organs such as liver and pancreas. Copyright left ventricular hypertrophy. O vascular dolichoectasias, elongations and distensions of the arteries caused by weakening of the vessel walls. Copyright cardiac valvular abnormalities, example defects of the mitral valve and the aortic root, annulus and / or valve. ADPKD. Copyright cystic dilatation of the collecting ducts. Other nephron segments are usually not affected. Degree hepatic fibrosis, see pathology section in cirrhosis. Differential diagnoses. Renal cysts. EC renal cysts. Acquired cystic kidney disease. Etiology. O no gene mutation. Copyright typically seen in advanced chronic kidney disease, especially in patients on renal replacement therapy. Scent clinical features. Copyright small, usually bilateral cysts. Multiple cysts, 4 cysts per kidney. Back collapse. Fine text outline. Scent clinical features. O small, usually bilateral cysts. O multiple cysts, 4 cysts per kidney. Copyright small to normal size kidney. Scent complications, cyst infection or bleeding, renal cell carcinoma. Scent diagnostics, ultrasound. Scent treatment, see treatment in renal cysts. Scent prevention, prevent or delay progression to ESRD, see treatment below, multicystic dysplastic kidneys. Scent definition, renal dysplasia with multiple cystic dilatations of nephrons during embryonic development. Etiology, predominantly non-hereditary. Scent pathophysiology. O sporadic occurrence during embryonic development of the ureter and nephrons. O defective interaction of the ureteric bud and the metanephric mesenchyme. Non-functional kidney with multiple cysts and connective tissue. Scent clinical features. Copyright onset, birth to childhood. O rarely symptomatic. O large cysts might impair urinary output, due to constriction of the urinary tract, usually unilateral cysts in the case of bilateral involvement. Degree equals Potter sequence, due to oligohydramnios, equals spontaneous abortion in case of failure of amniotic fluid production. Degree renal insufficiency is rare. Degree extrarenal manifestations, equals congenital heart defects, equals esophageal or intestinal atresia, equals spinal anomalies, equals bacterial association. Scent diagnostics, ultrasound showing unilateral, rarely bilateral, cysts of varying size. Scent treatment. Copyright surveillance in most cases. O nephrectomy is indicated in severe cases, example hypertension, progression of cyst growth. Scent prognosis. O most cases regress spontaneously. Copyright the non-dysplastic kidney usually functions properly and takes over the function of 2 kidneys. Autosomal dominant tubulointerstitial kidney disease, ADPKD, 17. Scent definition, a group of rare kidney diseases characterized by tubular damage and interstitial fibrosis in the absence of glomerular lesions. Etiology. O the 3 major genetic causes include autosomal dominant mutation of one of the following genes, 18UMOD, encoding uromodulin, 70% of cases, MUC1, encoding mucin 1, 30% of cases, 1-REN, encoding renin. Pathophysiology O ADK due to UMOD mutation accumulation of uromodulin within the cells of the thick ascending loop of Henle mitochondrial dysregulation tubular cell death chronic kidney disease equals uromodulin production apical expression of the NAK2Cl cotransporter T natriuresis compensatory proximal tubular sodium reabsorption secondary increase in proximal urate reabsorption hyperuricemia O ADK due to MUC1 mutation, possible dominant negative or gain of function effect of MUC1 mutation O ADK due to REN mutation, accumulation of preprorenin in the renal tubular cells apoptosis chronic kidney disease scent clinical features copyright small to normal size kidney copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia, OESRD usually develops between 30 to 60 years of age, copyright occasional bilateral cysts, mostly medullary O absent or minimal proteinuria with a bland urine sediment. Co-ADK due to UMOD mutation, gout since the adolescence. Copyright clinical findings associated with low renin in ADK due to REN mutation equals low to normal blood pressure equals hypoproliferative anemia in childhood equals mild hyperkalemia equals hyperuricemia scent diagnostics O ultrasound equals small kidneys in advanced stages of CKD equals medullary cysts can rarely be seen O genetic analysis provides a definitive diagnosis. Back collapse fine text outline. Scent pathology, tubulointerstitial fibrosis treatment copyright curative, kidney transplantation copyright treatment of chronic kidney disease O ADK due to UMOD mutation, allopurinol for gout O ADK due to REN mutation, fludrocortisone or high sodium diet may be used for low blood pressure, hyperkalemia and to potentially preserve kidney function. Plus prognosis, poor, due to progression of chronic kidney disease, 17. Medullary sponge kidney. Scent definition, calcified cysts originating from the collecting ducts and/or tubules in one or both kidneys plus epidemiology. Degree. 01/5000 persons copyright 12 to 20% of patients with calcific renal stones O the mean age of diagnosed patients is 27 years etiology most cases are sporadic some cases are attributed to genetic mutations pathophysiology, disruption at the ureteric bud-metanephric mesenchyme interface distal tubular acidification defect T urine pH and urinary stasis in the dilated ducts calcium phosphate and/or calcium oxalate lithogenesis clinical features usually asymptomatic. Incidental finding, copyright signs of nephrolithiasis, example colicky flank pain, copyright signs of urinary tract infection, example polyuria, dysuria, hematuria copyright painful excretion of small stones with the urinary flow is common diagnostics copyright ultrasound, dilatation of collecting ducts, cysts, and/or kidney stones, nonspecific, contrast CT urography, parallel striations from contrast which extend from the papilla to the medulla and persist on delayed imaging, papillary blush. Copyright IVP, irregular ectatic medullary collecting ducts, classic paintbrush-like appearance. Treatment prophylactic treatment of kidney stones with thiazide diuretics, high fluid intake, and/or potassium citrate extracorporeal shockwave lithotripsy for stones in collecting tubule in rare cases of kidney failure, renal dialysis may be required complications copyright recurrent UTIs can lead to renal obstruction copyright dilatation of the collecting ducts impaired renal filtration metabolic acidosis rarely, renal tubular acidosis, ESRD. Nephronophthisis, NPHP. Scent definition, a hereditary cystic kidney disease that typically manifests in childhood, characterized by renal ciliopathy, reduced renal concentration ability, and progression to ESRD plus epidemiology 2 degrees. Copyright incidence, 1/1,000,000 in the U.S. Copyright one of the most common genetic disorders leading to ESRD in children etiology autosomal recessive inheritance pattern mutations in genes encoding nephrocystin protein scent clinical features copyright similar clinical and histopathological features as ADK renal manifestations equals multiple, bilateral, mostly corticomedullary, kidney cysts equals polyuria, polydipsia, due to impaired ability to concentrate urine, equals signs of chronic tubulointerstitial nephritis equals signs of chronic kidney disease, example hypertension, fluid overload, anemia, uremia, equals ESRD usually develops before the age of 20 years to 21. Extrarenal manifestations, 10 to 20% of cases, include retinal defects, liver fibrosis, skeletal abnormalities, cardiac defects, or brain developmental disorders. Scent diagnostics. A renal ultrasound may reveal corticomedullary cysts. Copyright genetic analysis allows definitive diagnosis. Scent treatment. Treatment of chronic kidney disease. Copyright curative, kidney transplantation. Back collapse. Fine text outline. Obstructive cystic dysplasia. Scent definition. Renal dysplasia and cystic dilatation secondary to obstruction in the urinary tract, example ureteral stenosis, urethral agenesis, during fetal development. Etiology. Ureteral stenosis. Copyright posterior urethral valves. Copyright bladder outlet obstruction. Urethral agenesis. Copyright duplex collecting system with obstructing ureterocele. Copyright congenital vesicoureteric junction obstruction. Scent pathophysiology. Urinary tract obstruction. Urine retention in functioning nephrons. Formation of glomerular cysts in the nephrogenic zone. Scent clinical features. Copyright onset, birth to childhood. Copyright during pregnancy, oligohydramnios. The cause, the severity, and the timing of the obstruction determine the extent of symptoms. Equals asymptomatic in mild cases. Equals acute renal failure in severe cases. Extrarenal manifestations. Equals congenital heart defects. Equals CNS anomalies. Equals bacterial association. Scent diagnostics. Ultrasound showing unilateral or bilateral cysts of varying size. Cysts are usually smaller than those seen in patients with multicystic dysplastic kidneys. 22. Scent treatment. Elimination of the obstruction as a curative approach, example urethral valve ablation, von Hippel-Lindau disease. EC von Hippel-Lindau disease. The differential diagnoses listed here are not exhaustive. OSFA, IEEE. Treatment. Scent treatment / prevention of renal dysfunction. Degree ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, to prevent / treat hypertension as well as to slow proteinuria and ESRD progression. Copyright tolvaptan equals indicated in patients with rapidly progressing ADPKD and mild chronic kidney disease. GFR equals 25 ml/min/1.73 m2 and / or chronic kidney function estimated between 30 to 90%. 23 equals slows down the growth of kidney cysts in ADPKD patients. Equals delays progression to ESRD. Early treatment of urinary tract infections, to prevent renal cyst infection. Copyright high fluid intake to prevent kidney stone formation and to possibly slow cyst progression. Copyright avoid nephrotoxic substances, example NSAIDs, sulfonamide antibiotics, aminoglycosides. Avoid ADH, vasopressin may stimulate cyst growth, in severe cases, example ESRD, hemodialysis or peritoneal dialysis. Kidney transplantation is the only curative option. See also end-stage renal disease. Portosystemic shunting or liver transplantation may be required in ARPKD patients with severe hepatic involvement. Treatment of complications, example portal hypertension, subarachnoid hemorrhage. Scent general measures. Copyright regular sonographic monitoring and laboratory evaluation of renal function. Copyright regular sonographic and laboratory monitoring of liver and treatment of hepatic failure. Copyright genetic counseling. OOCE. Prognosis. ADPKD. Copyright 50% of ADPKD patients have ESRD requiring dialysis by the age of 60 years. 24 chronic hypertension and cerebral aneurysms, in particular, are associated with a poor prognosis. ARPKD. Neonates with severe cystic dilatation have a poor life expectancy. Probability of death within the 1 degree * year of life is 30%. 1-26 Copyright The majority of children who survive infancy have a life expectancy greater than 10 years. 25 Copyright The prognosis depends on the extent of renal and hepatic impairment. Back collapse. Find text outline. Copyright Onset, birth to childhood. Copyright during pregnancy, oligohydramnios. The cause, the severity, and the timing of the obstruction determine the extent of symptoms. Asymptomatic in mild cases. Acute renal failure in severe cases. Extrarenal manifestations. Congenital heart defects. CNS anomalies. Bacterial association. Scent diagnostics, ultrasound showing unilateral or bilateral cysts of varying size. Cysts are usually smaller than those seen in patients with multicystic dysplastic kidneys. 22 Scent treatment, elimination of the obstruction as a curative approach, example urethral valve ablation, von Hippel-Lindau disease. Scent. C. von Hippel-Lindau disease. The differential diagnoses listed here are not exhaustive. 70% Ashat. Treatment. Scent treatment/prevention of renal dysfunction. Degree ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, to prevent/treat hypertension as well as to slow proteinuria and ESRD progression, tolvaptan. Indicated in patients with rapidly progressing ADPKD and mild chronic kidney disease, GFR equals 25 ml/min/1.73 m2 n/or chronic kidney function estimated between 30 to 90%. 23 slows down the growth of kidney cysts in ADPKD patients. Delays progression to ESRD. Early treatment of urinary tract infections, to prevent renal cyst infection. Copyright high fluid intake to prevent kidney stone formation and to possibly slow cyst progression. Copyright avoid nephrotoxic substances, example NSAIDs, sulfonamide antibiotics, aminoglycosides. Copyright avoid ADH, vasopressin may stimulate cyst growth. Scent in severe cases, example ESRD, hemodialysis or peritoneal dialysis. Kidney transplantation is the only curative option. See also end-stage renal disease. Copyright portosystemic shunting or liver transplantation may be required in ARPKD patients with severe hepatic involvement. Copyright treatment of complications, example portal hypertension, subarachnoid hemorrhage, general measures. Copyright regular sonographic monitoring and laboratory evaluation of renal function. Copyright regular sonographic and laboratory monitoring of liver and treatment of hepatic failure. Copyright genetic counseling. VA and prognosis. ADPKD. Copyright 50% of ADPKD patients have ESRD requiring dialysis by the age of 60 years, 24 chronic hypertension and cerebral aneurysms, in particular, are associated with a poor prognosis. ARPKD. Neonates with severe cystic dilatation have a poor life expectancy, probability of death within the 15 year of life is 30%. 125 I-26, copyright the majority of children who survive infancy have a life expectancy greater than 10 years. 25 Copyright the prognosis depends on the extent of renal and hepatic impairment, renal cysts and enlargement lead to systemic hypertension and progressive renal failure. Progressive portal hypertension and hepatic fibrosis lead to liver failure. Dunauer N.E. A Red Notes fan. Sources. Last updated November 16, 2023. Back collapse. Find text outline. Polycystic kidney disease, 1/1. Autosomal dominant polycystic kidney disease. Extrarenal manifestations. Renal manifestations: flank or abdominal pain. Mitral valve prolapse, / enlarged kidneys with multiple cysts. Chronic kidney disease. Hypertension. SY, hepatic cysts. A copyright, recurrent urinary tract diverticulosis infections. Gross hematuria. Autosomal dominant polycystic kidney disease. VV copyright embark. Polycystic kidney disease, 1/4. 10 cents. Overlay. Polycystic kidneys in polycystic kidney disease VV ultrasound kidney, longitudinal view. Note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 1/4. 10.0. Copyright overlay. Polycystic kidneys in polycystic kidney disease VV ultrasound kidney, longitudinal view. Note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. Dip 5.017 fps. Overlay. Liver involvement in polycystic kidney disease VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. Dip 5.017 fps. Overlay. Liver involvement in polycystic kidney disease VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Uropolycystic kidney disease, 3/4. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Copyright. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Uropolycystic kidney disease, 4/4. Polycystic liver VV. Diagnostic laparoscopy of the liver. Numerous, variably sized, fluid-filled structures are seen on the surface of the liver. These findings are consistent with polycystic liver disease, which is commonly associated with polycystic kidney disease. Source: Copyright IMPP. Hepatic cysts in autosomal dominant polycystic kidney disease VV. Gross pathology: liver specimen, cross-section, multiple, variably sized, thin-walled lesions are visible within the liver parenchyma. These findings are consistent with polycystic liver disease, which is associated with autosomal dominant polycystic kidney disease. Source: Copyright IMPP. Multiple cysts in the kidney in ADPKD. Macroscopic image of the left kidney, which shows numerous cysts. These findings are consistent with autosomal dominant polycystic kidney disease, ADPKD. Source: Copyright IMPP. Polycystic kidney disease, 1/1. Overlay. Medullary sponge kidney VV. Ultrasound: right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 1/1. Copyright overlay. Medullary sponge kidney VV. Ultrasound: right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. X. Alport. Alport syndrome is a genetic disorder that is characterized by glomerulonephritis, often in combination with sensorineural hearing loss and sometimes eye abnormalities. It is caused by a genetic defect of type 4 collagen, which is usually inherited in an X-linked dominant pattern. Patients typically present with intermittent gross hematuria during infancy. In adolescence, patients classically start to develop more serious signs of chronic kidney disease, example proteinuria, and may experience hearing loss or, in rare cases, vision problems. In milder forms, patients may remain asymptomatic and only require monitoring. In classic Alport syndrome, diagnostic evaluation shows persistent microhematuria on urinalysis and splitting of the glomerular basement membrane on kidney biopsy. The classic form usually leads to end-stage renal disease, ESRD, between the second and third decade of life, and the only definitive treatment is a kidney transplant. OOE. Epidemiology. Plus rare disorder 1 cent. The most common hereditary nephritis epidemiological data refers to the U.S., unless otherwise specified. HO. Etiology. Plus usually X-linked, 80%. 1-4L* can also be autosomal recessive, 15%, or autosomal dominant, 5%. 4+ the disease tends to be more severe in males, 5. OOCES. Pathophysiology. Asterisk genetic defect of type 4 collagen chains, component of the basement membrane of the kidneys, eye, and cochlea, kidney damage, glomerulonephritis, sensorineural hearing loss, and ocular abnormalities. OCE. Clinical features. Plus age of onset can vary markedly among individuals, from infancy to late adulthood, depending on the underlying genetic defect. Often asymptomatic, initially intermittent gross hematuria, may present in infancy. As glomerular damage progresses, symptoms of nephritic syndrome and chronic kidney disease occur, usually leads to ESRD between 16 to 35 years of age. Sensorineural hearing loss. Ocular findings, retinopathy, anterior lenticonus, a congenital conical elevation at the anterior pole or posterior pole of the crystalline lens in the eye. Copyright anterior lenticonus may be seen in Allport syndrome, and a posterior lenticonus may be seen in Lowe's syndrome, oculocerebral renal syndrome. Copyright alenticonus appears as an oil globule in the center of the red reflex on direct ophthalmoscopy. And patients with Allport syndrome can't pee, can't see, can't hear a bee. X. Allport syndrome. Clinical features. Age of onset can vary markedly among individuals, from infancy to late adulthood, depending on the underlying genetic defect. Often asymptomatic. 1. Initially intermittent gross hematuria, may present in infancy. As glomerular damage progresses, symptoms of nephritic syndrome and chronic kidney disease occur, usually leads to ESRD between 16 to 35 years of age. 1. Sensorineural hearing loss. Ocular findings, retinopathy, anterior lenticonus, a congenital conical elevation at the anterior pole or posterior pole of the crystalline lens in the eye. Copyright anterior lenticonus may be seen in Allport syndrome, and a posterior lenticonus may be seen in Lowe's syndrome, oculocerebral renal syndrome. Copyright alenticonus appears as an oil globule in the center of the red reflex on direct ophthalmoscopy. QB. Patients with Allport syndrome can't pee, can't see, can't hear a bee. WA. CE. Diagnostics. Laboratory tests. Copyright urinalysis, best initial test, signs of nephritic syndrome, example hematuria, minor proteinuria, O-bun and creatinine to assess severity of renal disease. Skin biopsy. Copyright confirmatory test O shows absence of collagen type 4 alpha 5 chains. Kidney biopsy. Copyright light microscopy, mesangial cell proliferation and sclerosis, degree electron microscopy, splitting and alternating irregular thickening and thinning of the glomerular basement membrane, basket weave. Appearance. Immunofluorescence equals initially may be negative equals irregular deposits of IgM, IgG, and /or C3. Copyright immunostaining, absence of the type 4 collagen alpha 3, alpha 4, and /or alpha 5 chains in the basement membrane. Molecular genetic testing, can confirm and distinguish subtypes. Other audiometry, may detect high-frequency sensorineural hearing loss. Copyright ophthalmic evaluation, may detect anterior lenticonus, perimacular flex, and /or other eye abnormalities. Treatment. Monitor renal function regularly in patients with proteinuria, ACE inhibitors /angiotensin II receptor blockers. 1. In patients with renal failure, see treatment in chronic kidney disease, example sodium restriction, diuretics. Kidney transplant. Copyright the only definitive treatment of Allport syndrome. Copyright complication, Goodpasture disease can occur due to newly developed collagen type 4 antigens following a kidney transplant. 6. Hearing aids in patients with hearing loss. Consider ocular surgery in patients with lenticonus. Back collapse. Find text outline. Overlay. Anterior lenticonus in Allport syndrome. Slit lamp photograph of the right eye, mydriatic pupil. The light of the slit lamp produces an optical cross-section of the cornea, left optical cross-section, and the lens, right optical cross-section. Compared to the cornea, the anterior surface of the lens appears conical, normal physiological shape is indicated by the dashed line. This protrusion of the anterior cortex of the lens is referred to as anterior lenticonus, and it is associated with Alport syndrome. Source: Figure 1 in, clear lens phacoemulsification in the anterior lenticonus due to Alport syndrome, 2 case reports by Gassim Amir Aslanzadeh, Dawoud Garibaghi and Nilufar Nadari, Journal of Medical Case Reports, Biomed Central, licensed under CC by 2.0. T. 1. EY 111111. Copyright. Overlay. Anterior lenticonus in Alport syndrome. Slit lamp photograph of the right eye, mydriatic pupil. The light of the slit lamp produces an optical cross-section of the cornea, left optical cross-section, and the lens, right optical cross-section. Compared to the cornea, the anterior surface of the lens appears conical. Normal physiological shape is indicated by the dashed line. This protrusion of the anterior cortex of the lens is referred to as anterior lenticonus, and it is associated with Alport syndrome. Source: Figure 1 in, clear lens phacoemulsification in the anterior lenticonus due to Alport syndrome, 2 case reports by Gassim Amir Aslanzadeh, Dawoud Garibaghi and Nilufar Nadari, Journal of Medical Case Reports, Biomed Central, licensed under CC by 2.0. Euro Alport syndrome, 1/2. Histology of Alport syndrome VV. Photomicrograph of renal tissue, H&E stain, very high magnification. This glomerulus shows mild mesangial hypercellularity and thickening of glomerular capillaries. These discrete changes can be seen in Alport syndrome, although electron microscopy and/or genetic testing are necessary for this diagnosis. Source: Figure 1, in, compound mutations of the COL4A3 including a novel allele identified in a patient with Alport syndrome by Zhendong Wang, Baishun Zhang, Shiqi Jin, Zhao Hu, and Guanji Lu, Biomed Research International, licensed under CC by 4.0. Modifications: image was cropped. Alport syndrome, 2/2. I said. VAA1. Alport syndrome VV. Electron micrograph of a kidney biopsy sample. The glomerular basement membrane, GBM, demonstrates an irregular thickness, with splitting and a basket weave appearance, black arrow. These findings are consistent with Alport syndrome. Source: Figure 1, in, compound mutations of the COL4A3 including a novel allele identified in a patient with Alport syndrome by Zhendong Wang, Baishun Zhang, Shiqi Jin, Zhao Hu, and Guanji Lu, Biomed Research International, licensed under CC by 4.0. Modifications: image was cropped. X. Renal tubular disorders. Renal tubular disorders are a heterogeneous group of diseases that involve dysfunctions of transporters and channels in the renal tubular system. These dysfunctions may cause fluid loss and abnormalities in electrolyte and acid-base homeostasis. The disorders are either primary, genetic, or acquired, example drug adverse effects, renal disease. In renal tubular acidosis, RTA, there is normal anion gap, hyperchloremic, metabolic acidosis in a patient with normal or almost normal renal function. Types of RTA include distal tubular acid secretion, type 1, proximal tubular bicarbonate wasting, type 2, very rarely carbonic anhydrase deficiency, type IL, and aldosterone deficiency/resistance, type 4. Type 2 can be further classified into isolated proximal tubular bicarbonate wasting and generalized proximal tubular wasting, known as Fanconi syndrome. X-linked hypophosphatemic rickets, the most common form of hereditary hypophosphatemic rickets, is caused by phosphate wasting and manifests with hypophosphatemia and symptoms of rickets. Bartter syndrome, Little syndrome, syndrome of apparent mineralocorticoid excess, and Geidelman syndrome are inherited disorders of tubular function characterized by hypokalemia and metabolic alkalosis. Because renal tubular disorders manifest in heterogeneous ways, diagnosis is often challenging. It is based on a combination of clinical features, example rickets, impaired growth, symptoms of electrolyte deficiencies, laboratory analysis of blood and urine, and the results of investigations aimed at determining an underlying cause. The diagnosis of hereditary conditions is usually confirmed with genetic testing. Treatment of type 1 and type 2 RTA involves alkali therapy, while the treatment of type 4 RTA consists of furosemide therapy. X-linked hypophosphatemic rickets requires the supplementation of phosphate and vitamin D, while the mainstay of therapy for Bartter syndrome, Little syndrome, syndrome of apparent mineralocorticoid excess, and Geidelman syndrome involves lifelong oral potassium substitution with potassium-sparing diuretics. OOAO. Overview. Disorder. Bartter syndrome. Geidelman syndrome. X-linked hypophosphatemic rickets. RTA type 1. Renal tubular acidosis RTA type 2. RTA type 4. SIAD. Little syndrome. Syndrome of apparent mineralocorticoid excess. Back. Overview of renal tubular disorders pathophysiology blood plasma renin and PHY, GY pressure aldosterone. Asterisk normal/defective NAK-2CI cotransporter in the thick ascending loop of Henel 7FF. Defective thiazide-sensitive sodium chloride cotransporter in the distal convoluted normal/T tubule 1. Defective sodium phosphate cotransporter in the proximal renal tubule normal *N/A. The A intercalated cells of the distal tubule are unable to secrete H*, apical, 1 intracellular production of HCOs plus HCO3/CI exchanger activity, basolateral, normal N/A decreased concentration of HCO3 in the blood metabolic acidosis. The proximal convoluted tubule cells are unable to reabsorb HCO3 leading to increased HCO3 excretion in the urine. H** secretion from A intercalated cells in the collecting duct can acidify the urine, but cannot compensate for the excessive HCO excretion in the urine, thus resulting in *normal N/A distal tubular acidosis. In Fanconi syndrome, the reabsorption of HCO3 and other compounds, example potassium, glucose, phosphate, and amino acid reabsorption, in the PCT is also impaired. Aldosterone deficiency and/or resistance in the collecting duct and distal convoluted tubules, hyperkalemia, inhibition of ammonia, NH3, synthesis in the proximal foot EJ convoluted tubules, decreased urinary ammonium, NHQ*, excretion. 5. Normal/TADH secretion by the pituitary or an ectopic site, example small cell lung carcinoma, EDT. Defective epithelial sodium channel, ENAC, in the collecting duct OMOD. Mineralocorticoid receptor activity caused by excess cortisol as a result of 11-beta plus C. Hydroxysteroid dehydrogenase type 2, 11-beta HSD2, gene mutation. A. Collapse. Find text. Other characteristic findings. Similar to chronic loop diuretics, use EO hypercalciuria, copyright hypokalemia, copyright metabolic alkalosis. Similar to chronic thiazide diuretics, use O hypocalciuria, copyright hypomagnesemia, copyright hypokalemia, E metabolic alkalosis. Rickets, hypophosphatemia. Normal anion gap metabolic acidosis, hypokalemia, nephrocalcinosis, bone demineralization. Normal anion gap metabolic acidosis, vitamin D resistant hypophosphatemic tickets/osteomalacia, short stature, polyuria, Fanconi syndrome, OE hyporacemia, E hypophosphatemia. Normal anion gap metabolic acidosis, hyperkalemia, polyuria. Hyponatremia. Hypokalemia, metabolic alkalosis. High ratio of urinary free cortisol to cortisone, hypokalemia, metabolic alkalosis. Al. Outline. Renal tubular acidosis, RTA. In RTA, there is a normal anion gap metabolic acidosis in patients with normal or almost normal renal function. Plus renal tubular acidosis is caused by defects in the tubular transport of HCO, and/or H star. Most forms of RTA are asymptomatic, rarely, life-threatening electrolyte imbalances may occur. Type of RTA incidence. Cause. Pathophysiology. Serum P. Distal RTA, type 1, rare. Sporadic type 1 RTA, idiopathic, familial type 1 RTA, inherited genetic defects, autoimmune diseases, example systemic lupus erythematosus, chronic obstructive uropathy sickle cell nephropathy drugs, example ifosfamide, amphotericin B, lithium, NSAIDs. The A intercalated cells of the distal tubule are unable to secrete H star. Levels. Urine pH. Urine anion gap A. Calcium excretion. Bone involvement. Nephrolithiasis. Treatment. Positive. Increased. Bone demineralization without overt rickets or osteomalacia, due to increased bone turnover. Usually present. Alkali therapy with sodium bicarbonate or sodium citrate, Schall solution. Overview of types of renal tubular acidosis. Hit 2 proximal RTA, type 2, 3 very rare. Sporadic type 2 RTA, idiopathic, familial type 2 RTA, inherited genetic defects, Fanconi syndrome, see type 2 renal tubular acidosis below, drugs, acetazolamide multiple myeloma. The proximal convoluted tubule cells are unable to reabsorb HCO3. Hypokalemia. 5.5, an early finding of proximal RTA, attributed to continuous HCO3 excretion in the urine. Negative. Normal. Scent vitamin D resistant hypophosphatemic rickets/osteomalacia. Absent. Alkali therapy with orally administered potassium citrate. Mixed RTA, type 3. Scent extremely rare. Carbonic anhydrase 2 deficiency, autosomal recessive disease. Type 1 RTA with HCO3 wasting J. Hypokalemia. VVAA. Positive. Osteopetrosis. Absent. Alkali therapy with orally administered sodium citrate, Schall solution, or potassium citrate. Hyperkalemic RTA, type 4, common. Hypoaldosteronism. Copyright primary adrenal insufficiency, Addison disease, copyright diabetic nephropathy, diabetic hyporenism, copyright drugs, example NSAIDs, ACE inhibitors, heparin, cyclosporin, ARBs, aldosterone resistance. Copyright chronic interstitial or obstructive nephropathy. Copyright drugs, example potassium sparing diuretics, trimethoprim sulfamethoxazole. Aldosterone deficiency and/or resistance in the collecting duct and distal convoluted tubule cause hyperkalemia, which inhibits ammonia synthesis in the proximal convoluted tubule and decreases urinary ammonium excretion. Hyperkalemia. Positive. Normal or decreased. Bone demineralization without overt rickets or osteomalacia. Absent. Plus furosemide * mineralocorticoid replacement, fludrocortisone, low potassium diet. At patients with uremic acidosis, metabolic acidosis due to renal failure, have a decreased glomerular filtration rate, increased serum creatinine, and increased anion gap metabolic acidosis. Patients with renal tubular acidosis have relatively normal glomerular filtration rates and normal anion gap metabolic acidosis. Type 1 RTA, acid secretion impairment at distal tubule, treatment with alkali at. Type 4 RTA, aldosterone disorder, treatment with furosemide. Type 2 RTA, bicarbonate wasting at proximal tubule, treatment with BACE, Alkali, type 3 RTA, carbonic anhydrase deficiency, treatment with citrate, sodium/potassium. WA. Obud. Li distal renal tubular acidosis, type 1. Pathophysiology. The A intercalated cells of the distal tubule are unable to secrete H*, apical, intracellular production of HCO3 1-HCO3/Ci exchanger activity, basolateral, decreased concentration of HCO, in the blood metabolic acidosis, trademark. Etiology. Sporadic type 1 RTA, idiopathic, sent familial type 1 RTA, inherited genetic defects, autoimmune diseases. Back. A. Collapse. A. Find text. O. Outline. Autoimmune diseases: E. Systemic lupus erythematosus, E. Sjogren's syndrome, E. Rheumatoid arthritis, copyright primary biliary cirrhosis, E. Autoimmune hepatitis, E. Hashimoto thyroiditis and nephrocalcinosis, example hyperparathyroidism, vitamin D toxicity, sarcoidosis, E. medullary sponge kidney scent, chronic obstructive uropathy, example congenital anomalies, scent sickle cell nephropathy, scent Wilson disease, scent drugs, ifosfamide, amphotericin B, lithium, NSAIDs, analgesic nephropathy. Clinical features. Scent nephrocalcinosis, calcium phosphate stones, due to an increase in urine pH. Scent polyuria polydipsia, dehydration, bone demineralization, usually without overt rickets or osteomalacia, due to increased bone turnover. Scent impaired growth in some cases. Features of hypokalemia, example muscle weakness, hyporeflexia, paralysis, U waves, and flattened T waves on ECG. Diagnostics. Serum. O. Hyperchloremic metabolic acidosis, normal anion gap. O. Hypokalemia that improves with alkaline therapy, scent urine. O. Urine pH 25.5. Copyright acid load test, ammonium chloride acidification test. Following oral administration of ammonium chloride, the urine does not acidify, pH remains 5.3. Copyright positive urine anion gap. O. Hypercalciuria. Copyright decreased NH** excretion. O. Decreased citrate excretion. Treatment. Alkalinization therapy with orally administered sodium bicarbonate or sodium citrate, Schall solution. 2. Renal tubular acidosis type 1 causes kidney stones. References. IL-4. GVOOE. Li proximal renal tubular acidosis, type 2. Type 2 renal tubular acidosis is characterized by a dysfunctional proximal convoluted tubule, PCT, that is unable to reabsorb HCO3-. The defect can either be isolated, affecting only the reabsorption of HCO3, or, more commonly, the PCT has a generalized dysfunction of the PCT, in which case the condition is referred to as Fanconi syndrome. Isolated proximal RTA Fanconi syndrome. The proximal convoluted tubule cells are unable to reabsorb HCO3, leading to increased HCO3 excretion in the urine. H** secretion from A intercalated cells in the collecting duct can acidify the urine, but cannot compensate for the excessive HCO3 excretion in the urine, thus resulting in distal pathophysiology tubular acidosis. Idosis. 4. Sense impaired reabsorption of HCO3 and other compounds, example P. Scent inherited disorders. Degree cystinosis. Copyright tyrosinemia. Scent sporadic type 2 RTA, idiopathic, copyright galactosemia. Scent familial type 2 RTA, inherited genetic. Copyright type 1 glycogen storage disease defects, copyright Wilson disease. Etiology 1. Copyright autosomal recessive disease, more * light chain nephropathy, example multiple myeloma, common, E. autosomal dominant disease. Ischemia, acute tubular necrosis, amyloidosis. Drugs, acetazolamide. Vitamin D deficiency. Back collapse. Find text outline. Inherited disorders degree cystinosis copyright tyrosinemia * sporadic type 2 RTA, idiopathic, copyright galactosemia familial type 2 RTA, inherited genetic copyright type 1 glycogen storage disease defects, copyright Wilson disease etiology 3 copyright autosomal recessive disease, more * light chain nephropathy, example multiple myeloma, common, autosomal dominant disease ischemia, acute tubular necrosis, amyloidosis vitamin D deficiency paroxysmal nocturnal hemoglobinuria drugs, ifosfamide, tenofovir. Expired tetracyclines, aminoglycosides, cisplatin heavy metal poisoning, example lead, cadmium, mercury. Scent drugs, acetazolamide. Clinical features. Vitamin D-resistant hypophosphatemic rickets/osteomalacia, caused by phosphaturia and hypophosphatemia. Individuals with Fanconi syndrome typically have more severe symptoms: scent short stature, scent polyuria, polydipsia, dehydration in some cases. Features of hypokalemia, example muscle weakness, hyporeflexia, paralysis, U waves, and flattened T waves on ECG. Diagnostics. Scent serum. O hyperchloremic metabolic acidosis, I-scent. Normal anion gap, 5O hypokalemia that worsens with alkali therapy, copyright Fanconi syndrome equals hyporacemia equals hypophosphatemia urine O urine pH equals if serum HCOS3 is higher than its reabsorption threshold, pH 25.5 equals if serum HCOS is depleted, pH. O bicarbonate infusion test, urine pH rises to a level higher than 7.5 and the fractional excretion of bicarbonate is 15% following administration of 4-sodium bicarbonate _ O negative urine anion gap, copyright Fanconi syndrome equals aminoaciduria equals glucosuria despite normal or low serum glucose equals phosphaturia. Treatment. Plus alkali therapy with orally administered potassium citrate 1 * thiazide diuretics if alkali therapy is not tolerated or effective. I and B. Renal tubular acidosis type 2 has two variants: isolated proximal RTA and Fanconi syndrome. OSOE. ES mixed renal tubular acidosis, type 3. A combination of type 1 and type 2 RTA. Etiology. Scent carbonic anhydrase 2 deficiency, autosomal recessive disease. Pathophysiology. Impaired H secretion by the distal convoluted tubule and HCO wasting by the proximal convoluted tubule 1. Clinical features. Scent Gibaud-Vainsel syndrome, copyright osteopetrosis copyright cerebral calcification, copyright intellectual disability v. Back collapse, fine text outline. Diagnostics. Serum copyright hyperchloremic, normal anion gap, metabolic acidosis O hypokalemia O hypocalcemia urine copyright urine pH equals 5.5 copyright positive urine anion gap O hypercalciuria copyright decreased NH * excretion O decreased citrate excretion. Treatment. Scent alkali therapy with orally administered sodium citrate, Schall solution, or potassium citrate. WA. OES. Li hyperkalemic renal tubular acidosis, type 4. Etiology. Scent hypoaldosteronism O primary adrenal insufficiency, Addison disease, O hyporeninemic hypoaldosteronism acute glomerulonephritis 1 diabetic nephropathy, diabetic hyporenism, equals SLE equals AIDS nephropathy equals drugs, NSAIDs, cyclosporin copyright drugs, ARBs, ACE inhibitors, heparin, 6, O pseudohypoaldosteronism type 2, Gordon syndrome, an autosomal dominant condition characterized by increased sodium reabsorption and decreased potassium secretion due to dysfunction of ion channels in the kidney. Manifestations include hypertension, hyperkalemia, hyperchloremia, and metabolic acidosis. Aldosterone resistance. Copyright chronic obstructive nephropathy or interstitial nephropathy. Copyright drugs, potassium-sparing diuretics, example spironolactone, amiloride, eplerenone, triamterene, trimethoprim sulfamethoxazole, pentamidine. Pseudohypoaldosteronism type 1, a form of aldosterone resistance that is caused by an autosomal dominant loss of function mutation in the gene encoding for mineralocorticoid receptor protein or autosomal recessive loss of function mutations in the genes encoding the epithelial sodium channel. Pathophysiology. Aldosterone deficiency and/or resistance in the collecting duct and distal convoluted tubules, hyperkalemia and metabolic acidosis. Inhibition of ammonia, NH3, synthesis in the proximal convoluted tubules. Decreased urinary ammonium, NH*, excretion. Clinical features. Renal insufficiency, polyuria polydipsia, dehydration. Impaired growth in children. Features of hyperkalemia, example muscle weakness, prolonged PR interval and peak T waves on ECG. Diagnostics. Serum hyperchloremic metabolic acidosis, i.e., normal anion gap, hyperkalemia. Urine urine pH. Furosemide. Copyright ** mineralocorticoid replacement, fludrocortisone, 1 low potassium diet. Renal tubular acidosis type 4 leads to decreased NH** excretion. Back collapse. Fine text outline. X-linked hypophosphatemic rickets. Etiology. X-linked dominant disease caused by a mutation in the PHEX gene. Pathophysiology. Mutation in the PHEX gene equals increased levels of fibroblast growth factor 23, FGF23, 1 equals indirect inhibition of the sodium phosphate cotransporter in the proximal renal tubule. Impaired reabsorption of phosphate. Chronic hypophosphatemia. Vitamin D resistant rickets / osteomalacia. Epidemiology. X-linked hypophosphatemic rickets accounts for 80% of all familial causes of hypophosphatemia. Age of symptom onset, typically. Features of rickets, example short stature, bowing of legs, dental abscesses. Calcification of soft tissues, tendons, ligaments, and joint capsules, deafness. Arnold-Chiari malformation. Diagnostics. Laboratory tests. Co-pronounced hypophosphatemia. Copyright increased alkaline phosphatase. Copyright decreased or normal 1,25 dihydroxyvitamin D. Normal serum calcium, parathyroid hormone / parathyroid hormone related peptide, and 25 dihydroxyvitamin D. X-ray of the wrists, knees, ankles, and long bones, such as the femur. See diagnostics in osteomalacia and rickets. Treatment. Burosumab. Copyright drug of choice for children aged equals 1 year. A monoclonal antibody that targets FGF23 phosphate substitution. Calcitriol, 1,25 dihydroxyvitamin D, substitution. Complications of treatment, hyperparathyroidism, nephrocalcinosis. Copyright amiloride and hydrochlorothiazide are used to increase calcium reabsorption and thereby lower the risk of nephrocalcinosis. References. 7i8. 7yo8s. Bartter syndrome. Definition. A group of rare genetic disorders, autosomal recessive, that affect chloride reabsorption in the thick ascending limb of the loop of Henle. Epidemiology. Prevalence, 1/1,000,000. Pathophysiology. Defective NAK-2CI cotransporter in the thick ascending loop of Henle and S results in, plus loss of CI, Na, and K in urine, as seen in chronic loop diuretic use, plus failure to reabsorb Na*, leading to natriuresis, salt and water loss, and volume depletion, which activates the renin-angiotensin-aldosterone system, RAAS, leading to copyright renal vasoconstriction. However, a rise in prostaglandin E levels to counter renal vasoconstriction results in growth inhibition. Elevated aldosterone levels, leading to increased K** and H* excretion and subsequent hypokalemia and metabolic alkalosis and decreased paracellular reabsorption of calcium, hypercalciuria, hypocalcemia, nephrocalcinosis, and renal stones. Clinical features. Antenatal symptoms, polyhydramnios, preterm delivery plus severe polyuria and polydipsia, life-threatening volume depletion and hypotension. 1. Back collapse. Fine text outline. Clinical features. Antenatal symptoms, polyhydramnios, preterm delivery plus severe polyuria and polydipsia, life-threatening volume depletion and hypotension. Muscle atrophy, weakness, cramps, carpopedal spasm, scent failure to thrive, developmental delay, scent dysmorphic facies. 5. Strabismus, sensorineural deafness. Symptoms of renal colic may occur as a result of calcium stones. Diagnostics. Scent laboratory diagnostics. Copyright metabolic alkalosis. Hypokalemia. Hypercalciuria. Copyright hyperuricemia, 50% of cases. Response to thiazide and loop diuretics. Normal response to thiazide diuretics, blunted response to loop diuretics. 1 cent confirmatory test, genetic testing treatment. Mainstay of therapy, lifelong oral potassium substitution with potassium-sparing diuretics, spironolactone, amiloride. CE. The NAK2Cl cotransporter that is defective in Bartter syndrome is a target for loop diuretics. References: LL10. OOIEEE. Geidelman syndrome. Epidemiology. Prevalence: 1/40,000. Age of symptom onset, equals 6 years. Diagnosis is usually made in adolescence or adulthood. Etiology. Autosomal recessive defect in the SLC12A3 gene on chromosome 16p. Impaired function of the thiazide-sensitive sodium chloride cotransporter in the distal convoluted tubule. Impaired Na** and Ci reabsorption. Mild natriuresis. Mild volume depletion. Mild RAAS activation. Clinical features. Scent clinical features are similar to those of chronic thiazide diuretic use. Fatigue, muscle weakness, muscle cramps and/or tetany. Copyright mild polyuria. Copyright chondrocalcinosis. Copyright in some cases, mild hypotension. Diagnostics. Scent metabolic alkalosis. Scent severe hypokalemia ** hypercalcemia and hypocalciuria. Scent hypomagnesemia. Response to thiazide and loop diuretics. Normal response to loop diuretics, blunted response to thiazide diuretics. Scent confirmatory test, genetic testing treatment. Scent mainstay of therapy, lifelong oral potassium substitution with potassium-sparing diuretics, spironolactone, amiloride, as. And the effects of Geidelman syndrome are similar to those of a thiazide diuretic. Back collapse. Fine text outline. Little syndrome. Epidemiology. Extremely rare. Scent. Age of symptom onset, childhood. Etiology. Autosomal dominant gain of function mutation in the SCNN1B and SCNN1G genes on chromosome 16p. Structural alteration in the B and Y subunits of the epithelial sodium channel, ENAC, in the collecting duct. Pathophysiology. Structural alteration in the ENAC subunits. Inability of these subunits to bind with an intracellular ubiquitin protein ligase, NED4, decreased degradation of ENAC channels by ubiquitin proteasomes. Increased number of ENACs in the collecting duct. Increased reuptake of water and sodium, pseudohyperaldosteronism, hypertension with low renin production and hypokalemia. Clinical features. Scent hypertension. Diagnostics. Plus hypokalemia. Metabolic alkalosis. Scent decreased renin and aldosterone levels. Scent confirmatory test, genetic testing treatment. Lifelong oral potassium substitution with potassium-sparing diuretics that directly block ENACS in the collecting duct, example amiloride, triamterene. At the clinical features of Little syndrome are similar to those of hyperaldosteronism, except that Little syndrome manifests with decreased renin and aldosterone levels. OAE. Syndrome of apparent mineralocorticoid excess. Epidemiology, hereditary disorder, 11. Cent extremely rare 1 cent age of symptom onset, infancy etiology. Autosomal recessive, loss of function mutations in the 11-beta hydroxysteroid dehydrogenase type 2, 11-beta HSD2, gene on chromosome 16q 11-beta HSD2 enzyme. Cent acquired disorder from chronic exposure to glycyrrhetinic acid, example from excessive consumption of black licorice, which inhibits the activity of the 11-beta HSD2 enzyme. Pathophysiology. Cent with normal 11-beta HSD2 activity, 11-beta HSD2 converts cortisol into cortisone. Cortisone, unlike cortisol, does not activate mineralocorticoid receptors. Cent with 11-beta HSD2 deficiency, or inhibition cortisol conversion to cortisone T cortisol T mineralocorticoid receptor activity. Clinical features. Cent hypertension 1 cent low birth weight cent failure to thrive cent muscle weakness polyuria and polydipsia due to nephrogenic diabetes insipidus renal failure diagnostics. Cent best initial test, high ratio of urinary free cortisol to cortisone in a 24-hour urine collection Cent confirmatory test, genetic testing Cent additional findings EO hypokalemia. Back collapse find text outline. X renal tubular disorders. QB The clinical features of Little syndrome are similar to those of hyperaldosteronism, except that Little syndrome manifests with decreased renin and aldosterone levels. OO. OE. Syndrome of apparent mineralocorticoid excess. Epidemiology, hereditary disorder, 11. Plus extremely rare, 1 cent age of symptom onset, infancy etiology. Autosomal recessive, loss of function mutations in the 11-beta hydroxysteroid dehydrogenase type 2, 11-beta HSD2, gene on chromosome 16q 11-beta HSD2 enzyme. Acquired disorder from chronic exposure to glycyrrhetinic acid, example from excessive consumption of black licorice, which inhibits the activity of the 11-beta HSD2 enzyme. Pathophysiology. Cent with normal 11-beta HSD2 activity, 11-beta HSD2 converts cortisol into cortisone. Cortisone, unlike cortisol, does not activate mineralocorticoid receptors. Cent with 11-beta HSD2 deficiency, or inhibition cortisol conversion to cortisone 7 cortisol 1 mineralocorticoid receptor activity. Clinical features. Cent hypertension, 1 cent low birth weight cent failure to thrive cent muscle weakness polyuria and polydipsia due to nephrogenic diabetes insipidus renal failure diagnostics. Plus best initial test, high ratio of urinary free cortisol to cortisone in a 24-hour urine collection Cent confirmatory test, genetic testing Cent additional findings O hypokalemia O metabolic alkalosis O decreased renin and aldosterone levels O decreased urinary free cortisone excretion O hypercalciuria treatment. Cent cessation of licorice ingestion lifelong oral potassium substitution with potassium-sparing diuretics, example amiloride or eplerenone, to decrease the mineralocorticoid effects Cent thiazide in hypercalciuria or nephrocalcinosis corticosteroids, exogenous corticosteroid decreases endogenous cortisol production and subsequently reduces mineralocorticoid receptor activation. And spironolactone, an aldosterone receptor antagonist, is effective in treating the syndrome of apparent mineralocorticoid excess but not Little syndrome. And in syndrome of apparent mineralocorticoid excess, cortisol has the same action as aldosterone. Back collapse. Find text outline. Urorenal tubular disorders, 1/3. B equals CI/HO/CA/MG. Tiers OE nat /nat NAZP NAKAR NA *K, amino acids. 2 EE equals AEHCO, plus H *HT nat 4, L diffusion. HCO, equals ETHCO esristes equals SHCO, 3HCO, carbonic anhydrase J. 09 at 4, equals. Overview of the proximal convoluted tubule VV. The proximal convoluted tubule of the proximal nephron, left, facilitates the absorption of substances such as amino acids, glucose, and phosphate from urine. Absorption occurs via Na** importers that are dependent on the Na* gradient created by the Na/Kat posse pump. The transport of Na* from the tubular lumen, through the cell and into the interstitium generates a negative potential within the lumen, which drives the transport of bicarbonate, HCO3, into the cell. The enzyme carbonic anhydrase converts CO into HCO3, which then leaves the cell via the Na** importer. Copyright Boss. Equals 2\1,0 gu plus H0 aquaporin 2 aquaporin 3/4 /SSSH.0 principal cell for ROMK, K plus is XSGI arrows equals nat, Z equals E na. Hi, CHD, HAT posse 5, KY at. HCO, a type A4OT / intercalated cell OOHKAT posse U. H plus ODT arrays type B equals HCO, intercalated cell, 6. CR2 plus CR equals. Transport in the connecting tubule and collecting duct VV. The connecting tubule is the most distal part of the distal tubule. The physiological function of the connecting tubule and the collecting duct is to fine-tune the composition of the urine, which can also be regulated by hormones, not shown here. There are different types of cells. 1. Principal cells, upper part of the image, reabsorb water via aquaporins and contribute to sodium resorption via aldosterone-controlled sodium channels. 2. Intercalated cells mainly participate in the regulation of blood pH and are divided into type A/A and type B/F cells. Intercalated cells, middle part of the image, secrete protons into the lumen and transport bicarbonate into the interstitium. B. Intercalated cells, lower part of the image, transport protons into the interstitium and secrete bicarbonate into the lumen. Copyright Boss. Affected regions of a nephron in renal tubular defects. Copyright Boss. Geidelman syndrome, distal convoluted tubule. Syndrome of apparent mineralocorticoid excess, collecting duct. Little syndrome, collecting duct. X-linked hypophosphatemic rickets, proximal tubule. Fanconi syndrome, proximal convoluted tubule. Bartter syndrome, thick ascending limb of the loop of Henle. Equals 2\1,0 gu plus H0 aquaporin 2 aquaporin 3/4 /SSSH.0 principal cell for ROMK, K plus is XSGI arrows equals nat, Z equals E na. Hi, CHD, HAT posse 5, KY at. HCO, a type A4OT / intercalated cell OOHKAT posse U. H plus ODT arrays type B equals HCO, intercalated cell, 6. CR2 plus CR equals. Transport in the connecting tubule and collecting duct VV. The connecting tubule is the most distal part of the distal tubule. The physiological function of the connecting tubule and the collecting duct is to fine-tune the composition of the urine, which can also be regulated by hormones, not shown here. There are different types of cells. 1. Principal cells, upper part of the image, reabsorb water via aquaporins and contribute to sodium resorption via aldosterone-controlled sodium channels. 2. Intercalated cells mainly participate in the regulation of blood pH and are divided into type A/A and type B/F cells. Intercalated cells, middle part of the image, secrete protons into the lumen and transport bicarbonate into the interstitium. B. Intercalated cells, lower part of the image, transport protons into the interstitium and secrete bicarbonate into the lumen. Copyright Boss. Urorenal tubular disorders, 1/1. B equals CI/HO/CA/MG. Tiers OE nat /nat NAZP NAKAR POS NA*K, amino acids. 2 EE equals AEHCO, plus H*HT nat4, L diffusion. HCO, equals ETHCO S equals SHCO, 3HCO, carbonic anhydrase J. 09 at 4, equals. Overview of the proximal convoluted tubule VV. The proximal convoluted tubule of the proximal nephron, left, facilitates the absorption of substances such as amino acids, glucose, and phosphate from urine. Absorption occurs via Na*importers that are dependent on the Na* gradient created by the Na/Kat POS pump. The transport of Na* from the tubular lumen, through the cell and into the interstitium generates a negative potential within the lumen, which drives the transport of bicarbonate, HCO3, into the cell. The enzyme carbonic anhydrase converts CO into HCO3, which then leaves the cell via the Na* importer. Copyright Boss. Urorenal tubular disorders, 1/2. ////nat/ca2 /mg2 +++bwacpanin equals INA*TF cent NAKAT POS ASF PA ROMK and K7 SKA ENA*CR 2CLAGLKTK H0*. Transporters in the distal tubule, pars recta. The pars recta of the distal tubule is part of the loop of Henle and is also referred to as thick ascending limb. The loop of Henle is mainly responsible for urine concentration. In the ascending limb of the loop of Henle, sodium, potassium, and chloride are reabsorbed, via NKCC2. The basal Na plus K plus At POS A transports sodium out of the cell, and basal channels transport potassium and chloride. ROMK luminally transports potassium, creating a positive net charge in the tubular lumen. The charge serves as driving power for the paracellular reabsorption of cations like sodium, calcium, and magnesium via leaky tight junctions. This tubule section is impermeable for water. Copyright Boss. Equals 2\1,0 gu plus H0 aquaporin 2 aquaporin 3/4 /SSSH.0 principal cell for ROMK, K plus is XSGI arrows equals nat, Z equals E na. Hi, CHD, HAT POS A5, KY at HCO, a type A4OT / intercalated cell OOHKAT POS AU. H plus ODT arrays type B equals HCO, intercalated cell, 6. CR2 plus CR equals. Transport in the connecting tubule and collecting duct VV. The connecting tubule is the most distal part of the distal tubule. The physiological function of the connecting tubule and the collecting duct is to fine-tune the composition of the urine, which can also be regulated by hormones, not shown here. There are different types of cells. 1. Principal cells, upper part of the image, reabsorb water via aquaporins and contribute to sodium resorption via aldosterone-controlled sodium channels. 2. Intercalated cells mainly participate in the regulation of blood pH and are divided into type A/A and type B/F cells. Intercalated cells, middle part of the image, secrete protons into the lumen and transport bicarbonate into the interstitium. B. Intercalated cells, lower part of the image, transport protons into the interstitium and secrete bicarbonate into the lumen. Copyright Boss. X. Nephrotic syndrome. Nephrotic syndrome is a collection of signs and symptoms indicating damage to the glomerular filtration barrier. It is characterized by massive proteinuria, 3.5 g/24 hours, hypoalbuminemia, and edema. In adults, the most common causes of nephrotic syndrome include focal segmental glomerulosclerosis, FSGS, and membranous nephropathy. In children, nephrotic syndrome is most commonly caused by minimal change disease, MCD. Nephrotic syndrome can also be a manifestation of advanced renal disease in systemic conditions, example diabetic nephropathy or amyloid nephropathy. Typical laboratory findings of nephrotic syndrome include hyperlipidemia and fatty casts on urinalysis. Treatment for FSGS, membranous nephropathy, and MCD usually includes immunosuppressive therapy. Nephrotic syndrome due to advanced renal disease is associated with a worse prognosis and is more difficult to treat. See the section Core IM Podcast 5 Pearls on Nephrotic Syndrome for their complete show notes on this topic. VA OE Definition. Cent nephrotic range proteinuria, proteinuria 3.5 g/24 hours. Cent nephrotic syndrome, nephrotic range proteinuria plus hypoalbuminemia and edema type. WA OE Overview. Disease epidemiology. Asterisk most common cause of nephrotic syndrome in children minimal change disease, lipoid nephroses. Asterisk most common cause of nephrotic syndrome in adults, especially in African American and Hispanic populations. Focal segmental glomerulosclerosis. Most common cause of nephrotic syndrome in adults of European, Middle Eastern, or North African descent. Membranous nephropathy. Cent leading cause of ESRD in high diabetic nephropathy Iacum counties. Back. Differential diagonal of nephro-T 2, 3, 4, S, 6. Associations. Often idiopathic. Secondary causes, rare. Copyright immune stimulus, example infection, immunization, degree tumors, example Hodgkin lymphoma, copyright certain drugs, example NSAIDs. Can be idiopathic heroin use HIV infection. Sickle cell disease massive obesity. Interferon treatment congenital malformations, example Charcot-Marie-Tooth syndrome, 8L9. NPHS1 and NHPS2 mutations. Primary, anti-PLA2R antibodies. Secondary, infections, HPV, HCV, malaria, syphilis, autoimmune diseases, example SLE, tumors, example lung cancer, prostate cancer, medications, example NSAIDs. Degree. 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 Degree penicillamine, gold, 10. Cent usually additional signs of other organ system complications, example retinopathy, neuropathy. Add-in collapse. Findings. LM, no changes, possibly fat bodies in some proximal tubular cells. IM, negative M, effacement of podocyte foot. Processes selective glomerular proteinuria M7. LM, segmental sclerosis and hyalinosis. IM. E degree most commonly negative copyright possibly IgM, C1, and C3 deposits inside the sclerotic regions M, effacement of podocyte foot processes, similar to minimal change disease, LM. Copyright diffuse thickened glomerular capillary loops and basement membrane. A degree granular subepithelial deposits 4 of IgG and C3, dense deposits, spike and dome appearance. LM. Copyright thickening of the glomerular basement membrane, increased permeability. Copyright eosinophilic nodular glomerulosclerosis, Kimmels-Thiel-Wilson nodules, trademark. M. Copyright thickening of the glomerular basement membrane. Mesangial matrix expansion. Copyright segmental effacement of podocyte foot processes. Q. Find text. Treatment. Responds well to prednisone. Good prognosis. Prednisone often shows poor response, if necessary, plus other immunosuppressants, example cyclosporin, tacrolimus. RAAS inhibitors usually leads to ESRD if left untreated. RAAS inhibitors. Prednisone often shows poor response, plus other immunosuppressants, example cyclophosphamide, in severe disease usually leads to ESRD if left untreated. Asterisk stringent glycemic control. Sent RAAS inhibitors. Outline. Degree mesangial proliferation. The kidney is the most subendothelial and or subepithelial commonly affected organ in immune complex deposition. Degree. Systemic amyloidosis. Copyright thickening of the capillary walls. Sent other organs might be involved, appear as wire loops, asterisk melphalan, corticosteroids asterisk more commonly seen in elderly simultaneously, example the heart. Copyright Congo red stain, amyloid deposition in asterisk treatment of underlying disease, example Snavioltiapinonami patients. I1 sent multiple PLE mice myeloma, ALAL the mesanphaeum showing IG apple green apple G. Bone marrow transplantation PP. May YB amyloidosis, birefringence under polarized light, used for multiple myeloma, sent chronic inflammatory disease, degree nodular glomerulosclerosis example tuberculosis, rheumatoid plus IM, positive for AA protein, AAINs, anadisia-Es, amyloidosis, positive for kappa and lambda light chains, AL amyloidosis, sent M, amyloid fibrils. Usually manifests with nephritic sediment, which can indicate membranoproliferative. Copyright nephrotic syndrome, if there is concomitant nephrotic range proteinuria, 3.5 g/24 hours, glomerulonephritis. Degree pure nephritic syndrome, if there is no proteinuria or proteinuria is below nephrotic range. Etiology. Nephrotic syndrome may be caused by primary glomerular disorders, 80 to 90% of cases, and or systemic diseases and toxic exposures, 10 to 20% of cases. 12. Sent primary, idiopathic, forms. The following types of nephrotic syndrome are commonly associated with other conditions. See the overview section. O. Minimal change disease. O. Focal segmental glomerulosclerosis. Co-membranous nephropathy. Copyright membranoproliferative glomerulonephritis, can manifest as nephrotic or nephritic syndrome. Secondary forms. Degree diabetic nephropathy. Amyloid nephropathy, can be associated with multiple myeloma, AL amyloidosis, or chronic inflammatory disease such as rheumatoid arthritis, AA amyloidosis. Lupus nephritis, can manifest as nephrotic or nephritic syndrome. Degree. Pathophysiology. Damage of glomerular filtration barrier, 3IL-14. Sent minimal change disease, cytokine-mediated damage of podocytes. A. Sent focal segmental glomerulosclerosis, sclerosis of glomeruli. Damage and loss of podocytes. Membranous nephropathy, antiphospholipase A2 receptor antibodies, anti-PLA2R antibodies, bind to PLA2R, an autoantigen in glomerular podocytes, and thereby form immune complexes that activate the complement system, leading to podocyte injury. 15. Membranoproliferative glomerulonephritis, See pathophysiology in nephritic syndrome. Scent diabetic glomerulonephropathy, see pathophysiology in diabetic nephropathy. Scent amyloid nephropathy, copyright deposition of amyloid, example AL amyloidosis, AA amyloidosis, in various organs, the kidney is the most commonly involved organ, copyright amyloid deposition in glomeruli 5, mesangial expansion nodular sclerosis, 16. Scent lupus nephritis, see pathophysiology in lupus nephritis. B and FSGS is classically not associated with immune complex deposition. Sequelae of glomerular filter damage, 130-114. Back collapse, find text outline. Sequelae of glomerular filter damage, 131-I14. Scent structural damage of glomerular filtration barrier, massive renal loss of protein, hyperproteinuria, reactively increased hepatic protein synthesis, O loss of negative charge of glomerular basement membrane, loss of selectivity of barrier, especially for negatively charged albumin, 1O podocyte damage and fusion, non-selective proteinuria, except in minimal change disease, which manifests with selective glomerular proteinuria, 7 Scent if protein loss exceeds hepatic synthesis, usually with a loss of protein 3.5 g/24 hours, hypoproteinemia/hypoalbuminemia, initially with both normal GFR and creatinine, 13 IL-14 IOJ, serum albumin colloid, osmotic pressure plus edema, especially if albumin levels are hypercoagulability, O loss of transport proteins. Equals loss of thyroglobulin transport protein, thyroxine deficiency. Equals vitamin D binding protein, vitamin D deficiency, copyright loss of plasma proteins, plasma protein binding, increase in free plasma drug concentration, but drug toxicity is usually not increased. 18-19-21 plasma levels of cholesterol, LDL, triglycerides, and lipoproteins, mainly LPA, to compensate for the loss of albumin, lipiduria, fatty casts, 21 Scent loss of immunoglobulins, increased risk of infection, especially Streptococcus pneumoniae infection, pulmonary edema also increases the risk for S. pneumoniae infection, Scent sodium retention, possible hypertension. OS. OCO. Clinical features. Scent classic manifestations, O massive proteinuria 3.5 g/24 hours, O edema equals typically starts with periorbital edema, equals peripheral edema, pitting, equals pleural effusion, equals pericardial effusion, equals ascites, equals in severe cases, anosarca, O hypoalbuminemia, O hyperlipidemia. Scent other clinical features, O hypercoagulable state with increased risk of thrombosis and embolic events, example pulmonary embolism, renal vein thrombosis, copyright increased susceptibility to infection, O hypertension in some cases, copyright possibly frothy urine, O symptoms of hypocalcemia, example tetany, paresthesia, muscle spasms, copyright symptoms of the underlying disease, example malar rash in lupus nephritis. Scent see also nephrotic versus nephritic syndrome. ZO. As. Diagnostics. Initial evaluation 221,112. Confirmation of nephrotic range proteinuria. Asterisk qualitative assessment by urine dipstick, commonly used for screening, O usually shows equals 3 plus proteins. EO hematuria may indicate concomitant glomerulonephritis. Scent quantitative assessment of urine protein excretion, copyright 24-hour urine protein, test of choice 3.5 g/24 hours, 1, 231 I241 I25, copyright spot urine protein /creatinine ratio, 3.5 g/G261 L23. Urine sediment microscopy 271. Back collapse, find text outline. Urine sediment microscopy 271. Scent nephrotic sediment, copyright lipiduria, Fatty casts with Maltese cross appearance under polarized light. A renal tubular epithelial cell cast sent hematuria with acanthocytes and/or RBC casts may indicate concomitant glomerulonephritis. See diagnostics in nephritic syndrome. Additional laboratory studies. CBC, THB/HCT may indicate hemoconcentration. BMP, 7-CRN/or T-bun may be seen, NIS commonly seen. Serum protein, total protein, albumin. Imaging. Renal ultrasound, to assess kidney size and shape and rule out obstruction. Subsequent evaluation 22-12. Additional testing to assess for potential concomitant conditions and underlying causes should be based on clinical suspicion. 30. Workup for concomitant conditions and underlying causes of nephrotic syndrome. Suspected condition. Recommended studies * serum glucose, diabetic nephropathy, HbA1c. Antiplaque antibodies, 1 membranous nephropathy, PONS * age appropriate cancer screening, Ana lupus nephritis * antidsna * C3C4. Multiple myeloma * serum protein electrophoresis and immune fixation, and other plasma cell dyscrasia. Sent urine protein electrophoresis and immune fixation. HIV of chronic viral infection * HBsAg * HCV of. Syphili relistas FTAABS cryoglobulins, cryoglobulinemia C3, C4. Degree. PPY genetic testing. Renal biopsy 221I121. Sent indication, to confirm the diagnosis when the etiology of nephrotic syndrome is unclear and/or to guide management. Interpretation, see the pathology section. VA5. Pathology. Classification of nephrotic syndrome is based on the pattern of injury as seen on light microscopy, LM, of a renal biopsy specimen. For a complete assessment, all biopsy specimens should be analyzed using LM, immunofluorescence microscopy, IM, and electron microscopy, M. Back collapse. Fine text outline. Sent minimal change disease. OM, effacement of the foot processes of podocytes. OLM, no changes in glomeruli, possibly fat bodies in some proximal tubular cells. Sent focal segmental glomerulosclerosis, damage to podocytes. OM, effacement of the foot processes, similar to minimal change disease. OLM, segmental sclerosis and hyalinosis and loss of podocytes. MOIM, rarely, focal deposits of IgM, C1, and C3 inside sclerotic lesions. Sent membranous nephropathy, deposition of antibodies between podocytes and the basal membrane PA. OLM, diffuse thickening of glomerular capillary loops and basal membrane. OIM, granular subepithelial deposits of immune complexes and complement. 1. Sent diabetic glomerulonephropathy, light microscopy shows mesangial matrix expansion, thickening of glomerular membrane, and/or nodular eosinophilic glomerulosclerosis, Kimmel-Steele-Wilson lesions. Sent lupus nephritis, light microscopy shows mesangial proliferation, subendothelial and/or subepithelial immune complex deposition, and thickening of the capillary walls, appear as wire loops. Sent amyloid nephropathy. OM, amyloid fibrils. OLM equals nodular glomerulosclerosis equals apple green birefringence, mesangial amyloid deposition, with Congo red stain under polarized light. Feedback VY for your notes. Faux shared notes. Treatment. Management of symptoms and complications of nephrotic syndrome 22-12-21. Edema 22-12-1. Plus dietary sodium restriction. Copyright options equals first line, oral loop diuretic, example furosemide, 221,721 equals second line, equals add oral thiazide or thiazide-like diuretic, example metolazone, equals and/or switch to 4-loop diuretic, example 4 furosemide, equals consider adjunctive for albumin 54. Elimination or reduction of proteinuria is a major treatment goal for nephrotic syndrome and can lead to increased serum albumin, decreased edema, attenuation of the metabolic effects of heavy proteinuria, example hyperlipidemia, reduction in risk of thromboembolism and infection, and slowing of the progression of chronic kidney disease. SENT antiproteinuric therapy indicated in most patients 1-ORAAS inhibitor, ACEI, example ramipril, or ARB, example losartan, are commonly used. IL-22-235 equals effects equals reduces proteinuria equals treats hypertension equals may slow progression of any underlying renal example diabetic nephropathy, equals avoid in patients with ACI, hyperkalemia, or abrupt onset of nephrotic syndrome. Other measures that may be beneficial in combination with an ACEI or ARB, equals low sodium diet 3-1-thiazide diuretic, example hydrochlorothiazide, 6 equals mineralocorticoid receptor antagonist, example spironolactone, 37 plus dietary protein, avoid very high protein diet but ensure adequate protein intake. 38. Dyslipidemia 221 I11 I39. Back collapse find text outline. Dyslipidemia 221 I11 39. SENT lipid lowering therapy, example atorvastatin, SENT indications similar to those in other patients with a high risk of cardiovascular disease, see treatment in lipid disorders. Hypercoagulability, 1L22-240. All patients with nephrotic syndrome are at increased risk of thromboembolism, and this risk becomes progressively higher as serum albumin drops below 3.0 g/L. SENT prophylactic anticoagulation copyright options unfractionated heparin, 2-OLL equals low molecular weight heparin, example enoxaparin, 40* oral warfarin, target INR 2.0 to 3.0, OLL equals evidence for direct oral anticoagulants, DOACs, is lacking, consider only in patients who are unable to tolerate unfractionated heparin, low molecular weight heparin, or warfarin, 401. Infectious risk 41. Plus preventive measures. Pneumococcal vaccination, annual vaccination for influenza disease specific measures 132. Plus primary forms of nephrotic glomerulopathies, often treated with immunosuppressive therapy. Immunosuppressive therapies may include, equals glucocorticoids, often used initially, equals additional immunosuppressants, example cyclophosphamide, calcineurin inhibitors, in patients with steroid-resistant nephrotic syndrome or severe disease. Management in adults is usually guided by biopsy-based histological diagnosis. Copyright children are often treated initially with empiric corticosteroids for presumed MCD, 421. Secondary forms of nephrotic glomerulopathies, treat the underlying cause. Primary membranous nephropathy, 1. Plus initial management, conservative therapy including an RAAS inhibitor, i.e., ACEI or ARB, 5U1. Consider immunosuppressive therapy for severe or refractory disease. Prednisone and cyclophosphamide, JFO alternatives, cyclosporin, tacrolimus, or rituximab. Primary, idiopathic, focal segmental glomerulosclerosis, FSGS, 1. Initial management, supportive therapy including an RAAS inhibitor, i.e., ACEI or ARB. SENT consider immunosuppressive therapy for all patients with nephrotic syndrome due to FSGS. Copyright prednisone, 1. Copyright alternative, calcineurin inhibitor, cyclosporin or tacrolimus. Primary, idiopathic, minimal change disease, MCD, 1. Initial management, immunosuppressive therapy. Copyright prednisone 6. Copyright alternative, cyclophosphamide or calcineurin inhibitor. Diabetic nephropathy 43. Sent strict glycemic control ERAAS inhibition, example ACEI or ARB. Sent optimization of blood pressure control. Sent close surveillance and timely referral to renal replacement therapy if ESRD is anticipated. EC diabetic nephropathy. For more information. Amyloid nephropathy 44. Treatment of the underlying disease OAL amyloidosis, treatment of multiple myeloma or other plasma cell dyscrasia. Copyright AA amyloidosis, treatment of underlying inflammatory condition EC amyloidosis and multiple myeloma. For more information. Lupus nephritis. EC treatment in lupus nephritis. Back collapse. Find text outline. Complications. Thrombotic complications /45. Sent venous thromboembolism, example deep vein thrombosis, pulmonary embolism, sent arterial thromboembolism plus renal vein thrombosis, thrombus formation in the renal veins or their branches. 46. Cause, hypercoagulable state, example malignancies, antiphospholipid syndrome, nephrotic syndrome. Copyright 47. Copyright manifestations equals flank pain equals hematuria 1 LDH equals anuria renal failure in bilateral thrombosis equals scrotal edema. Diagnostics equals CT angiography or Mr. Venography, preferred modality in patients with renal injury or failure, equals Doppler ultrasonography if no other diagnostic modality is available. O treatment equals anticoagulation equals thrombolysis or thrombectomy in selected patients. Copyright complications, rupture of renal capsule, pulmonary embolism, kidney injury. Atherosclerotic complications 451,148. Abnormal lipid metabolism in combination with a hypercoagulable state leads to an increased risk of atherosclerotic complications. Sent manifestation, myocardial infarction, stroke. Chronic kidney disease. FSGS and membranous nephropathy in particular may progress to chronic kidney disease and ESRD. Increased risk of infection. 491L50L. Sent most likely resulting from hypogammaglobulinemia caused by urinary protein loss. Sent e.g., respiratory tract infections, peritonitis, urinary tract infections, sepsis. Sent especially with encapsulated bacteria, example Streptococcus pneumoniae, protein malnutrition. Loss in lean body mass due to proteinuria may be masked by weight gain caused by concurrent edema. Vitamin D deficiency. Due to urinary loss of vitamin D binding protein, DBP, and bound 25-hydroxyvitamin D11L52-ILS3 can cause hypocalcemia. TT serum parathyroid hormone, PTH, bone disease, see secondary and tertiary hyperparathyroidism, 54 anemia. Sent due to urinary loss or impaired synthesis of transferrin, causing hypochromic microcytic anemia, transcobalamin, causing megaloblastic anemia, copper, causing sideroblastic anemia, erythropoietin, and iron. 55. We list the most important complications. The selection is not exhaustive. AUGUOFOT. Differential diagnoses. Sent C. Nephrotic versus nephritic syndrome. Lupus nephritis, example diffuse proliferative glomerulonephritis. The differential diagnoses listed here are not exhaustive. 7. CE. Prognosis. Sent the prognosis for minimal change disease is usually excellent. With a wide variety of underlying diseases, the response to treatment can differ dramatically. Individuals with nephrotic syndrome often develop progressive renal failure despite treatment and go on to require dialysis. Back collapse. Find text outline. Nephrotic syndrome, 1/10. Minimal change disease V. Photomicrograph of tissue obtained from renal biopsy, H&E stain, 200x magnification, the basement membrane of the glomerulus are intact, the mesangium does not show proliferation. The capillary lumens are visible and there are no vascular changes. This is a typical appearance of a glomerulus in minimal change disease. Source: light microscopy of the patient's renal biopsy tissue by way ETAL, License C Biomed Central. 2014, Biomed Central. 2014, licensed under CC by 4.0. Uronephrotic syndrome, 2/10. Overlay. Podocyte foot processes fusion in minimal change disease VV. Electron micrograph of kidney tissue. The effacement of the podocytes foot processes is visible, examples indicated by green outline, as well as swelling of podocyte bodies, example indicated by red overlay. This finding, together with unremarkable light microscopy, is typical of minimal change disease. Source: Figure 2, electron microscopy demonstrating minimal change nephropathy by Darren Saitio, Ahmed El Mater, Journal of Medical Case Reports, licensed under CC by 2.0. Uronephrotic syndrome, 3/10. Focal segmental glomerulosclerosis, FSGS, VV. Photomicrograph of a kidney biopsy specimen, PA stain, very high magnification, a cross-section of a glomerulus is visible at the center of the image. The perihilar region is hypercellular and contains hyaline deposits, examples indicated by blue overlay. Loss of the capillary lumens and diffuse sclerosis is also present. These are the typical features of focal segmental glomerulosclerosis, perihilar type. Source: Focal segmental glomerulosclerosis, High Mag by Michael Bonert, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 3/10. Overlay. Focal segmental glomerulosclerosis, FSGS, VV. Photomicrograph of a kidney biopsy specimen, PA stain, very high magnification, a cross-section of a glomerulus is visible at the center of the image. The perihilar region is hypercellular and contains hyaline deposits, examples indicated by blue overlay. Loss of the capillary lumens and diffuse sclerosis is also present. These are the typical features of focal segmental glomerulosclerosis, perihilar type. Source: Focal segmental glomerulosclerosis, High Mag by Michael Bonert, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Nephrotic syndrome, 4/10. Focal segmental glomerulosclerosis VV. Electron micrograph ultrastructural findings of focal segmental glomerulosclerosis showing podocyte foot process effacement, thin black arrows, and protein reabsorption droplet, white arrow. Endothelial cells show tubuloarticular inclusions in the upper right-hand corner, star. Effacement of podocyte foot processes is commonly seen in electron microscopy samples of focal segmental glomerulosclerosis. Source: Figure 4, in collapsing focal segmental glomerulosclerosis in a patient with systemic lupus erythematosus by Hassan Tariq, Arsalan Rafiq, Giovanni Franchin, Case Reports in Medicine, licensed under CC by SA 3.0. Uronephrotic syndrome, 5/10. Overlay. Membranous nephropathy VV photomicrograph of a kidney biopsy sample, PA stain, 550x magnification, there is diffuse thickening of the glomerular basement membrane, blue overlay, and capillaries. These are typical microscopic findings of membranous glomerulopathy, most common glomerulonephritis in adults. Source: Membranous nephropathy, PA, very high mag JPG by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Nephrotic syndrome, 5/10. Overlay. Membranous nephropathy V photomicrograph of a kidney biopsy sample, PA stain, 550x magnification, there is diffuse thickening of the glomerular basement membrane, blue overlay, and capillaries. These are typical microscopic findings of membranous glomerulopathy, most common glomerulonephritis in adults. Source: membranous nephropathy, POT, very high mag JPG by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 6/10. SZ overlay. Membranous nephropathy VV. Photomicrograph of a kidney biopsy specimen, Jones silver stain, very high magnification, thickening of the basement membrane, indicated by yellow outlines, with spike formation, examples indicated by blue arrowheads, can be seen. This histopathologic appearance is characteristic of membranous nephropathy. Source: membranous nephropathy, cropped, MPAS, very high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Membranous nephropathy VV. Photomicrograph of a kidney biopsy specimen, Jones silver stain, very high magnification, thickening of the basement membrane, indicated by yellow outlines, with spike formation, examples indicated by blue arrowheads, can be seen. This histopathologic appearance is characteristic of membranous nephropathy. Source: membranous nephropathy, cropped, MPAS, very high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 7/10. Overlay. Diabetic nephropathy VV. Photomicrograph of kidney tissue, PA stain, high magnification, a cross-section of a glomerulus can be seen, dashed outline, featuring a thickened glomerular basement membrane and containing abundant pink, hyaline depositions of PA-positive material, Kimmel-Steele-Wilson nodules or nodular glomerulosclerosis, examples indicated by yellow overlay. Various tubules and vessels surround the glomerulus. An arteriole with distinct hyaline deposits is located above the glomerulus, hyaline arteriolosclerosis, blue overlay. Nodular glomerulosclerosis combined with hyaline arteriolosclerosis is a typical feature seen in diabetic glomerulopathy. Source: light micrograph of a kidney showing nodular glomerulosclerosis in a case of diabetic nephropathy by Doc Murray, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 7/10. Overlay. Diabetic nephropathy VV. Photomicrograph of kidney tissue, PA stain, high magnification, a cross-section of a glomerulus can be seen, dashed outline, featuring a thickened glomerular basement membrane and containing abundant pink, hyaline depositions of PA-positive material, Kimmel-Steele-Wilson nodules or nodular glomerulosclerosis, examples indicated by yellow overlay. Various tubules and vessels surround the glomerulus. An arteriole with distinct hyaline deposits is located above the glomerulus, hyaline arteriolosclerosis, blue overlay. Nodular glomerulosclerosis combined with hyaline arteriolosclerosis is a typical feature seen in diabetic glomerulopathy. Source: light micrograph of a kidney showing nodular glomerulosclerosis in a case of diabetic nephropathy by Doc Murray, Wikimedia Commons, licensed under CC by SA 3.0. Nephrotic syndrome, 8/10. Overlay. Diabetic nephropathy VV. Photomicrograph of a kidney autopsy specimen, H&E stain, 400x magnification, nodular glomerulosclerosis in diabetic nephropathy, Kimmel-Steele-Wilson syndrome, displays with mesangial thickening due to nodular, hyaline deposits, Kimmel-Steele-Wilson lesions, yellow overlay, within the glomerulus, blue overlay. Further findings include thickening of the tubular basement membranes, tubular atrophy, and an increase of interstitial connective tissue between renal tubules, interstitial fibrosis. Nodular glomerulosclerosis takes a decade or longer to develop in diabetes mellitus. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, Pediatric Alberto Perez Buza, Focharst für Pathology. Nephrotic syndrome, 8/10. Overlay. Diabetic nephropathy VV. Photomicrograph of a kidney autopsy specimen, H&E stain, 400x magnification, nodular glomerulosclerosis in diabetic nephropathy, Kimmel-Steele-Wilson syndrome, displays with mesangial thickening due to nodular, hyaline deposits, Kimmel-Steele-Wilson lesions, yellow overlay, within the glomerulus, blue overlay. Further findings include thickening of the tubular basement membranes, tubular atrophy, and an increase of interstitial connective tissue between renal tubules, interstitial fibrosis. Nodular glomerulosclerosis takes a decade or longer to develop in diabetes mellitus. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, Pediatric Alberto Perez Buza, Focharst für Pathology. For Smart Zoom Viewer. QOPFI. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. Arteriosclerosis. The walls of the arterioles are thickened with hyaline caused by mucopolysaccharide deposits. The reduced blood supply causes a reflex production of renin and therefore causes hypertension, which only worsens arteriosclerosis, a vicious circle. If Owen. Hyaline caused by mucopolysaccharide deposits. The walls of the arcuate arteries are thickened with, reduced blood supply causes a reflex production of on SY. Arteriosclerosis Y. Ling SY3AG. 7. Yen. Number 5. TESE. IPE. TE. RA7 PAA. Cent SSSEI. NE, E. PITAD OE. OE plus. R. WTASMI. MWE. Equals. Add BPE. Equals. OE. ES, J. Of AE. A. OA. TT. SR Neil SES. My. AE Olf. Smart Zoom Viewer. N plus 6E. SASE. New York 6 TES. NE, asterisk 5T. PJ.A asterisk. % OS. B. Asterisk EPS. Pound at. / \A, O, I, FSTD ma F. E asterisk I. TEEESEEEO 128 FME, SAXA and 1. NIP 74. Is 2. BS2. E. STE. My. TEVS Aries S. EY. PAOE plus BES. A. EG. X. And cent EEEVE. Smart Zoom Viewer. \5, sclerotic glomerulus. Another example of a sclerotic glomerulus with significant eosinophilic, knotty, hyaline structures, classic signs of diabetic nephropathy. PW powered by Smart Zoom. Copyright 2023 Smart in Media. OIAD / ES. Smart Zoom Viewer. L at E plus. OETL. Parts of the glomerulus can barely be recognized. The capillaries are hyalinized, podocytes and Bowman space are hardly visible. Because parts of the glomerulus are still intact yet this part is sclerotic, this is known as segmental glomerular necrosis. Smart Zoom Viewer. Mesangial deposits. A classic diabetic nephropathy in nodular diabetic glomerulosclerosis is characterized by the spread of knotty, homogeneous hyaline deposits throughout the mesangium. These are PA+ with a routine PA stain and are a sign of advanced disease. Smart Zoom Viewer. 41J. Glomerular sclerosis. Parts of the glomerulus can barely be recognized. The capillaries are hyalinized, podocytes and Bowman capsule are hardly visible. Because parts of the glomerulus are still intact yet this part is sclerotic, this is known as segmental glomerular sclerosis. X Smart Zoom Viewer. Mens. SEEP tissue autolysis X equals ESTA *WR. *77 and as trademark this tissue is from an autopsy, which explains the S-ERSEY autolytic changes in parts of the tissue. OI copyright J. Plus. Smart Zoom Viewer. Y. Hyaline thickening of afferent arteriole wall X fu. _ at VA degree equals. In this afferent arteriole, a marked hyaline thickening *A equals E at * of the wall is sign of advanced arteriosclerosis and KYIOTY, MI, sent unremarkable finding in diabetic patients with micro, OY *, E *S *, and macroangiopathy. Registered plus, Yates OE / *EO. _ Uronephrotic syndrome, 9/10. Lupus nephritis. Photomicrograph of a renal cortex biopsy, PA stain, high magnification. The mesangial and endothelial proliferation of the glomerulus has resulted in the dislocation of the capillary lumen and thickening of the capillary wall, creating the appearance of wire loops. This is the typical appearance of proliferative glomerulonephritis. Source: Diffuse Proliferative Lupus Nephritis by Michael Bonard, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Kidney involvement in amyloidosis, 2 of 2. Polarized light photomicrograph of the kidney, Congo red stain, 300x magnification. The sediments in the area of the glomeruli and renal interstitium, white arrowheads, appear birefringent in the polarized light and bright green in color, characteristic of amyloids. These are both key diagnostic features of amyloid sediments. Source: Copyright IMPP. Distal convoluted tubule macula densa. Extraglomerular afferent arteriole juxtaglomerular for mesangial cells apparatus efferent arteriole. 5. Extracellular matrix. Mesangial matrix. Juxtaglomerular cells year. Podocytes, visceral layer of YALA at, on SS. In, Bowman's capsule. Is E at / podocyte processes WANQN equals S _ YY, petty cells, glomerular basement membrane fenestrated capillary endothelium. Parietal layer of Bowman's capsule proximal tubule. Cross-section of renal corpuscle VV. The renal corpuscle consists of the glomerulus, the glomerular, Bowman, capsule, and the juxtaglomerular apparatus. Plasma components are filtered from the fenestrated glomerular capillaries across the glomerular filtration barrier into the urinary space within the Bowman capsule. The juxtaglomerular apparatus consists of the macula densa, the extraglomerular mesangial cells, and the juxtaglomerular cells. It maintains systemic arterial blood pressure. Copyright Embark. Renal glomeruli. Transverse section. Copyright Embark. Podocyte glomerular basement membrane. Endothelial cell, fenestrated capillary endothelium, microfibrils mesangial cell extracellular matrix. Uronephrotic syndrome, 1/2. Maltese cross sign. Polarized light micrograph of lyotropic liquid crystals. These La liquid crystals have a characteristic Maltese cross appearance under polarized light. Fatty casts from urinary sediment have the same appearance under polarized light. Source, Figure 4a, in Development and Characterization of Nanostructured Pharmacosomal Mesophases, an Innovative Deliver Bioactive Peptides by Mariam Revani, Javed Hezari, Syed Hadi Payambardist, Maria Manconi, Hamed Hamisha R., Advanced Pharmaceutical Bulletin, licensed under CC by 4.0. Modifications, image cropped. Albumin ALA2BY nephrotic syndrome JVLA, albumin A2BY serum protein electrophoresis in nephrotic syndrome VV. Copyright Embark. Uronephrotic syndrome, 1/8. Overlay. Podocyte foot processes fusion in minimal change disease VV. Electron micrograph of kidney tissue. The effacement of the podocytes foot processes is visible, examples indicated by green outline, as well as swelling of podocyte bodies, example indicated by red overlay. This finding, together with unremarkable light microscopy, is typical of minimal change disease. Source, Figure 2, Electron microscopy demonstrating minimal change nephropathy by Darren Saitio, Ahmed El Mater, Journal of Medical Case Reports, licensed under CC by 2.0. Nephrotic syndrome, 2/8. Minimal change disease V. Photomicrograph of tissue obtained from renal biopsy, H&E stain, 200x magnification. The basement membrane of the glomerulus are intact, the mesangium does not show proliferation. The capillary lumens are visible and there are no vascular changes. This is a typical appearance of a glomerulus in minimal change disease. Source, light microscopy of the patient's renal biopsy tissue by way ETAL, licensee Biomed Central. 2014, Biomed Central. 2014, licensed under CC by 4.0. Nephrotic syndrome, 3/8. Focal segmental glomerulosclerosis VV. Electron micrograph ultrastructural findings of focal segmental glomerulosclerosis showing podocyte foot process effacement, thin black arrows, and protein reabsorption droplet, white arrow. Endothelial cells show tubuloarticular inclusions in the upper right-hand corner, star. Effacement of podocyte foot processes is commonly seen in electron microscopy samples of focal segmental glomerulosclerosis. Source, Figure 4, in Collapsing focal segmental glomerulosclerosis in a patient with systemic lupus erythematosus by Hassan Tariq, Arsalan Rafiq, Giovanni Franchin, Case Reports in Medicine, licensed under CC by SA 3.0. Uronephrotic syndrome, 4/8. Overlay. Focal segmental glomerulosclerosis, FSGS, VV. Photomicrograph of a kidney biopsy specimen, PA stain, very high magnification, a cross-section of a glomerulus is visible at the center of the image. The perihilar region is hypercellular and contains hyaline deposits, examples indicated by blue overlay. Loss of the capillary lumens and diffuse sclerosis is also present. These are the typical features of focal segmental glomerulosclerosis, perihilar type. Source, Focal segmental glomerulosclerosis, High Mag by Michael Bonert, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 5/8. Overlay. Membranous nephropathy VV photomicrograph of a kidney biopsy sample, PA stain, 550x magnification, there is diffuse thickening of the glomerular basement membrane, blue overlay, and capillaries. These are typical microscopic findings of membranous glomerulopathy, most common glomerulonephritis in adults. Source: membranous nephropathy, PA, very high mag JPG by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Nephrotic syndrome, 5/8. Overlay. Membranous nephropathy v photomicrograph of a kidney biopsy sample, PA stain, 550x magnification, there is diffuse thickening of the glomerular basement membrane, blue overlay, and capillaries. These are typical microscopic findings of membranous glomerulopathy, most common glomerulonephritis in adults. Source: membranous nephropathy, PA, very high mag JPG by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Nephrotic syndrome, 6/8. Overlay. Diabetic nephropathy VV. Photomicrograph of a kidney autopsy specimen, H&E stain, 400x magnification, nodular glomerulosclerosis in diabetic nephropathy, Kimmel-Steele-Wilson syndrome, displays with mesangial thickening due to nodular, hyaline deposits, Kimmel-Steele-Wilson lesions, yellow overlay, within the glomerulus, blue overlay. Further findings include thickening of the tubular basement membranes, tubular atrophy, and an increase of interstitial connective tissue between renal tubules, interstitial fibrosis. Nodular glomerulosclerosis takes a decade or longer to develop in diabetes mellitus. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, PDDRMED Alberto Perez Buza, Focharst für Pathology. Uronephrotic syndrome, 7/8. Overlay. Diabetic nephropathy VV. Photomicrograph of kidney tissue, PA stain, high magnification, a cross-section of a glomerulus can be seen, dashed outline, featuring a thickened glomerular basement membrane and containing abundant pink, hyaline depositions of PA-positive material, Kimmel-Steele-Wilson nodules or nodular glomerulosclerosis, examples indicated by yellow overlay. Various tubules and vessels surround the glomerulus. An arteriole with distinct hyaline deposits is located above the glomerulus, hyaline arteriolosclerosis, blue overlay. Nodular glomerulosclerosis combined with hyaline arteriolosclerosis is a typical feature seen in diabetic glomerulopathy. Source: light micrograph of a kidney showing nodular glomerulosclerosis in a case of diabetic nephropathy by Doc Mari, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 7/8. Overlay. Diabetic nephropathy VV. Photomicrograph of kidney tissue, PA stain, high magnification, a cross-section of a glomerulus can be seen, dashed outline, featuring a thickened glomerular basement membrane and containing abundant pink, hyaline depositions of PA-positive material, Kimmel-Steele-Wilson nodules or nodular glomerulosclerosis, examples indicated by yellow overlay. Various tubules and vessels surround the glomerulus. An arteriole with distinct hyaline deposits is located above the glomerulus, hyaline arteriolosclerosis, blue overlay. Nodular glomerulosclerosis combined with hyaline arteriolosclerosis is a typical feature seen in diabetic glomerulopathy. Source: light micrograph of a kidney showing nodular glomerulosclerosis in a case of diabetic nephropathy by Doc Mari, Wikimedia Commons, licensed under CC by SA 3.0. Uronephrotic syndrome, 8/8. Lupus nephritis. Photomicrograph of a renal cortex biopsy, PA stain, high magnification, the mesangial and endothelial proliferation of the glomerulus has resulted in the dislocation of the capillary lumen and thickening of the capillary wall, creating the appearance of wire loops. This is the typical appearance of proliferative glomerulonephritis. Source: Diffuse Proliferative Lupus Nephritis by Michael Bonard, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. X. Proteinuria. Proteinuria is defined as a urinary protein excretion of 150 mg per day. It has many possible causes, which may be benign, example fever, intense exercise, dehydration, or more serious, example glomerulonephritis, multiple myeloma. There are three different pathophysiological mechanisms that may lead to proteinuria: damage to the glomeruli, glomerular, damage to the tubules, tubular, or overproduction of low molecular weight proteins, overflow. If proteinuria is detected, patients should be further evaluated, example additional urinalysis, to determine the underlying cause. The detection of microalbuminuria is of particular importance, as it suggests early diabetic or hypertensive nephropathy. AE. Definition: proteinuria equals urinary protein excretion of 150 mg per day. WACE. Diagnosis: urinalysis sent urine dipstick, repeat to rule out transient proteinuria, primarily detects albumin, sent sulfosalicylic acid test, sulfosalicylic acid is added to urine to measure total urine proteins, not specific for albumin, E24-hour urine collection or urine protein to creatinine ratio in a spot urine sample to rule out orthostatic proteinuria, urine sediment to rule out glomerular disease, sent electrophoresis to rule out tubulointerstitial diseases and multiple myeloma QB. Proteinuria can cause foamy urine. Diagnosis of underlying disease: C. Differential diagnoses of nephrotic syndrome. C. Diabetes mellitus. Sent C. Multiple myeloma. References: OSCE. Classification: according to quantity. Microalbuminuria. Urine albumin excretion of 3300 mg/day. Diagnosis is made if 2 out of 3 tests are positive. Sent early symptom of diabetic nephropathy and hypertensive nephropathy. Sent specific urine dipstick tests, radioimmunoassay, or ELISA required for detection overt proteinuria, formerly macroalbuminuria. Sent urine albumin excretion 300 mg per day. Sent standard urine dipstick tests can be used for detection. Sent nephrotic syndrome, massive proteinuria, 3.5 g/24h, hypoalbuminemia, edema, and hyperlipidemia according to origin. Glomerular proteinuria 223. Damage to the glomeruli, increased permeability of the glomerular filtration barrier, urinary protein excretion. Sent characteristic finding, appearance of large proteins in the urine. Copyright selective glomerular proteinuria, loss of negative charge of glomerular basement membrane. Only small to medium-sized proteins can be found in the urine, primarily albumin, can be found in diseases with mild damage to the glomeruli, example minimal change disease, IgA nephropathy. X. Proteinuria. Overt proteinuria, formerly macroalbuminuria. Urine albumin excretion 300 mg per day. Standard urine dipstick tests can be used for detection. Sent nephrotic syndrome, massive proteinuria, 3.5 g/24h, hypoalbuminemia, edema, and hyperlipidemia according to origin. Glomerular proteinuria 2I3. Damage to the glomeruli, increased permeability of the glomerular filtration barrier, urinary protein excretion. Sent characteristic finding, appearance of large proteins in the urine. Copyright selective glomerular proteinuria loss of negative charge of glomerular basement membrane only small to medium-sized proteins can be found in the urine, primarily albumin, can be found in diseases with mild damage to the glomeruli, example minimal change disease, IgA nephropathy, O non-selective. Glomerular proteinuria damage to the glomerular basement membrane all types of protein of any size can be found in the urine, albumin, transferrin, and IgG are commonly detected, equals can be found in diseases with severe damage to the glomeruli and subsequent permeability to all components of the blood, example rapidly progressive glomerulonephritis, lupus nephritis, amyloid nephropathy. Tubular proteinuria. Damage to the tubules, failure to reabsorb small proteins in the tubules, urinary protein excretion. The detection of beta-2 microglobulin without large proteins is typical. Scent can be found in tubulointerstitial nephritis, analgesics nephropathy, acute renal failure. Mixed proteinuria. Scent found in diseases that affect both the glomeruli and the tubules, example chronic renal failure. Prerenal proteinuria, or overflow proteinuria. Scent increased production of low molecular weight proteins. The reabsorption capacity of the tubules is exceeded. O light chains or Bence-Jones protein, C. myeloma kidney, O hemoglobinuria, in hemolysis, O myoglobinuria, in rhabdomyolysis. Postrenal proteinuria. Scent proteins that are being produced in the tubules, TAM horseful protein, E proteins that reach the urine in the lower urinary tract, example trauma or inflammation. WA. OOXE. Benign proteinuria. Scent defined as isolated proteinuria. DN. Back collapse, fine text outline. XX nephritic syndrome. Nephritic syndrome is characterized by glomerular capillary damage leading to hematuria, pyuria, water retention, and subsequent hypertension and edema. It can be caused by a variety of conditions including autoimmune, hereditary, and infectious DI. Nephritic DI can manifest with varying degrees of severity, ranging from asymptomatic hematuria to systemic involvement, as in rapidly progressive glomerulonephritis. The urine sediment is typically characterized by red blood cell casts, mild to moderate proteinuria. WA. OOSO. Definition. Nephritic syndrome is an inflammatory process that is defined as the presence of one or more of the following: 1. Scent hematuria with acanthocytes RBC casts in urine, proteinuria. And nephritic syndrome indicates glomerular inflammation. WA. 6. Overview. Post-streptococcal glomerulonephritis. IgA nephropathy, Berger DID. Granulomatosis with polyangiitis. Small vessel vasculitis, microscopic polyangiitis. Eosinophilic granulomatosis with polyangiitis, Churg-Strauss syndrome. Back. Epidemiology. Scent usually affects children 3 to 12 years of age and elderly patients too. Most common type of idiopathic glomerulonephritis. Worldwide incidence, #3 peak incidence, 2 to 34 decade of life 41. Slightly more common in men. Peak incidence, 65 to 74 years, 6. Slightly more common in men. Scent peak incidence, 50 to 60 years 1. Least common type of small vessel vasculitides. Peak incidence, 38 to 54 years, 8. Diseases associated with nephritic syndrome. Clinical features. Occurs weeks after group AB hemolytic streptococcal infections. Copyright pharyngitis/tonsillitis, most common 1 to 2 weeks after infection. Degree skin infections, 3 to 4 weeks after infection. Periorbital and peripheral edema. Hypertension. Tea or cola-colored urine, usually self-limiting in children, may lead to rapidly progressive glomerulonephritis, RPGN, renal insufficiency in adults. Asymptomatic microhematuria with intermittent gross hematuria during or directly after one or more of the following: O. Upper respiratory tract infections. Degree gastrointestinal infections. Copyright strenuous exercise. 25 to 30% of patients progress to end-stage renal disease, ESRD, within 20 years of diagnosis. 6. Pulmonary and nasopharyngeal involvement is common, may manifest with hemoptysis- and nasal ulcers. Can cause pauciimmune RPGN. Usually only mild respiratory symptoms can cause pauciimmune RPGN. Asthma, allergic rhinitis, purpura, peripheral neuropathy can cause pauciimmune RPGN. B. Collapse. A. Find text. Diagnostics. Positive anti-streptococcal antibodies, ASO, ATB, for serum C3 complement levels, due to consumption, type IL hypersensitivity reaction LM, glomeruli appear enlarged and hypercellular. If granular subepithelial immune complex depositions, IgG, IgM, C3, along the GBM and the mesangium, copyright so-called lumpy, bumpy or starry sky appearance. Electron microscopy, M dome-shaped, subepithelial immune complex deposits, humps. T serum IgA normal, C3 complement levels, renal pathology, findings of IgA vasculitis, OLM, mesangial proliferation OIF, mesangial IgA immune complex deposits OM, mesangial immune complex deposits. C. ANCA/PR3 ANCA type 4 hypersensitivity reaction, renal biopsy, segmental necrotizing glomerulonephritis. P. ANCA/MPO ANCA. P. ANCA/MPO ANCA peripheral eosinophilia, focal segmental necrotizing glomerulonephritis. Outline. Goodpasture syndrome, anti-GBM antibody disease. Thin basement membrane. Nephropathy, benign familial hematuria. Alport syndrome. Diffuse proliferative glomerulonephritis, DPGN. Rapidly progressive glomerulonephritis, RPGN. Membranoproliferative glomerulonephritis, MPGN. 2 peaks of occurrence, 9, copyright 20 to 30 years, $7, copyright 60 to 70 years, $at. Estimated to affect 5 to 10% of the general population. 85% of cases X-linked dominant, $7, 15% autosomal recessive. 1. Severe disease typically manifests during adolescence. Most common and severe manifestation of lupus nephritis in systemic lupus erythematosus, SLE, also seen with IgA nephropathy and with other inflammatory, autoimmune, or infectious diseases. Occurrence, 7 equals. Peak incidence, 60 to 85 years. 2. Primary disease occurs mainly in children. Pulmonary infiltrates on chest X-ray, pulmonary hemorrhage, and usually presents as RPGN type anti-GBM glomerulonephritis, glomerulonephritis in the presence of anti-GBM antibodies without lung involvement. Hereditary disorder, persistent microhematuria and episodic gross hematuria, example following an upper respiratory tract infection or exercise, good prognosis. Mutation in gene encoding type 4 collagen associated with sensorineural hearing loss and abnormalities of the eye, anterior lenticonus, retinopathy, LA often leads to ESRD. Can also be nephritic with nephrotic range proteinuria, nephritic syndrome, can lead to immune complex RPGN. Renal function declines rapidly over days to weeks, not a disease entity itself but a possible manifestation of glomerulonephritis. Poor prognosis, can progress to ESRD within weeks to months. Most commonly nephritic, but severe forms can also be nephrotic immunoglobulin, Ig, mediated membranoproliferative glomerulonephritis, type 1 MPGN. Associated with SLE, monoclonal gammopathy. Degree can also be idiopathic complement-mediated membranoproliferative glomerulonephritis, type 2 MPGN, associated with dense deposit disease, IgG antibodies that stabilize C3 convertase. I.e., C3 nephritic factor, cause a persistent complement activation, leading to a depletion of C3, both associated with HBV, HCV, and cryoglobulinemia. Copyright hereditary diseases, example sickle cell disease, a 1 antitrypsin deficiency, 13-degree drugs, example heroin, interferon, copyright tumors, example lymphoma, copyright autoimmune diseases, example SLE. May manifest with concomitant nephrotic range proteinuria, nephritic syndrome. Asterisk caused by antibodies against type 4 collagen asterisk type IL hypersensitivity reaction hemosiderin-filled macrophages in sputum iron deficiency anemia if, linear deposition of immunoglobulin, IgG, along the glomerular basement membrane, and the alveolar basement membrane in the lung. Abnormalities of type 4 collagen M, diffuse thinning of glomerular basement membrane. Persistent microhematuria with intermittent gross hematuria M, splitting and alternating thickening and thinning of the glomerular basement membrane, lamellated and basket weave appearance. Serum C3 complement levels ANA, anti-DNA antibodies LM copyright thickening of glomerular capillaries, appear as wire loops, law copyright characterized by increased glomerular cellularity in more than half of the glomeruli IM, granular appearance ME most commonly subendothelial immune deposits, IgG immune complexes, C3, and C1q. OE less commonly subepithelial or intramembranous deposits. LM, if, M copyright crescent formation, moon-shaped, made of plasma proteins, example C3b and fibrin degree monocytes, macrophages. Glomerular parietal cells can be caused by a variety of diseases categorized in 3 groups according to their IM pattern. Degree linear, Goodpasture syndrome, anti-GBM disease, copyright granular, immune complex RPGN. Equals post-streptococcal glomerulonephritis equals diffuse proliferative glomerulonephritis, most common with SLE, degree negative, pauciimmune RPGN. Equals granulomatosis with polyangiitis equals microscopic polyangiitis equals eosinophilic granulomatosis with polyangiitis. IG-mediated, type 1. Copyright IV, subendothelial and mesangial IgG immune complex deposits with granular appearance E serum C3 complement levels complement mediated, type 2. Copyright intramembranous C3 deposits, dense deposit disease, on basement membrane O serum C3 complement levels both types, LM with HNE or PA stain shows mesangial ingrowth, which leads to thickening and splitting of the glomerular basement membrane, tram track appearance, A. IM equals I4A LM equals light me M equals LI pi. And low serum C3 levels are seen in post-streptococcal glomerulonephritis, lupus nephritis, and membranoproliferative glomerulonephritis. A. Collapse fine text. Al. Outline. Pathophysiology. Cent general pathophysiology inflammation cytokine release glomerular capillary damage equals porous glomerular basement membrane leakage of proteins and RBCs nephritic sediment, all blood components are detectable on urinalysis, equals proteinuria. Intravascular volume expansion hypertension and edema, cent membranoproliferative glomerulonephritis, characterized by deposition of antibodies between podocytes and the basal membrane O membranoproliferative glomerulonephritis type 1, subendothelial immune complex deposits activation of the classical complement pathway cell injury, mesangial proliferation, and matrix expansion 1. O membranoproliferative glomerulonephritis type 2, dense deposit disease intramembranous deposition of complement C3, C3 nephritic factor, and IgG. Autoantibody that stabilizes C3 convertase and continuously activates C3, leading to its depletion, activation of the alternative complement pathway. Good shared notes. Clinical features. Scent intermittent gross hematuria, red or brown urine, i.e., cola-colored urine, scent hypertension pitting edema, E and JGFR, oliguria and uremic symptoms, see uremia, scent for a comparison of nephrotic and nephritic syndrome, see nephrotic versus nephritic syndrome. PV 0 shared I. Diagnostics plus urinalysis, nephritic sediment, 4O hematuria, either microhematuria or intermittent macrohematuria, O acanthocytes, O red blood cell casts, RBC casts form through the congregation of proteins and RBCs inside the tubules. Copyright mild to moderate proteinuria of 150 mg/24 Bud. Q. Glomerular hematuria is a typical finding in nephritic syndrome. It is characterized by acanthocytes, RBC casts, and mild to moderate proteinuria. Non-glomerular hematuria is characterized by bright red or pink urine, the occurrence of blood clots, normal RBC morphology, and the absence of RBC casts. Differential diagnoses. Sense C nephrotic versus nephritic syndrome. The differential diagnoses listed here are not exhaustive. Back collapse, find text outline. X nephritic syndrome. Clinical features. Plus intermittent gross hematuria, red or brown urine, i.e., cola-colored urine, scent hypertension plus pitting edema, scent in JGFR, oliguria and uremic symptoms, see uremia, scent for a comparison of nephrotic and nephritic syndrome, see nephrotic versus nephritic syndrome. OS and diagnostics. Plus urinalysis, nephritic sediment, 41. O hematuria, either microhematuria or intermittent macrohematuria, copyright acanthocytes, O red blood cell casts, RBC casts form through the congregation of proteins and RBCs inside the tubules. M. Copyright mild to moderate proteinuria of 150 mg/24 Bud. Q. And glomerular hematuria is a typical finding in nephritic syndrome. It is characterized by acanthocytes, RBC casts, and mild to moderate proteinuria. Non-glomerular hematuria is characterized by bright red or pink urine, the occurrence of blood clots, normal RBC morphology, and the absence of RBC casts. Degree EA, OEE Can 2, Euro CRI. Differential diagnoses. Sense C nephrotic versus nephritic syndrome. The differential diagnoses listed here are not exhaustive. OA5. Treatment. Scent supportive therapy, E. Low sodium diet, O. Water restriction, scent medical therapy, O. If proteinuria and or hypertension, angiotensin converting enzyme inhibitors or angiotensin receptor blockers, O. If severe hypertension and or edema, diuretics, O.E. Sometimes immunosuppressive therapy is indicated, example in lupus nephritis. Copyright if RPGN from anti-GBM antibody disease, plasmapheresis, scent in the case of, copyright severe renal insufficiency or kidney failure, renal replacement therapy, example hemodialysis, possibly transplantation, copyright membranoproliferative glomerulonephritis, type 1 and type 2 MPGN, RAAS inhibitors are often added to treatment prednisone alone or in combination with other immunosuppressants, cyclosporin or tacrolimus. Back collapse, find text outline. Uronephritic syndrome, 1/8. A equals, O. 4 EEO asterisk AEOPIA. Nat, OG OSNE/. Overlay. Post-infectious glomerulonephritis VV. Microscopic image of a kidney biopsy, PA stain, high magnification. A renal corpuscle surrounded by numerous tubules can be seen in the center of the image. Because the renal corpuscle is markedly enlarged, the space between the glomerular capillaries and the parietal layer of the Bowman capsule, black dashed outline, is narrowed. Within the glomerulus, There is hypercellularity due to proliferation of endothelial cells, yellow arrowheads, and mesangial cells, black arrowheads. Inflammatory infiltrate, predominantly neutrophils, blue arrowheads, and monocytes, white arrowheads, is also present. As a result, the lumina of the capillaries are not clearly identifiable. This is the histopathologic appearance of post-infectious glomerulonephritis. Source: Post-infectious glomerulonephritis, very high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephritic syndrome, 2/8. Blood vessel. Lysosomal enzymes equals SASS equals RF as RF immune complexes F/% X \OPK C4 at C5 IANN 3 equals C1 ESYAA A/CC Basement membrane Endothelial cell damaged endothelial cell Type 3 hypersensitivity reaction. Immune complexes, antigen-antibody complexes, are formed in the circulation and get deposited in tissues, preferably within the vascular endothelium, certain organs, example kidney, lung, and the serosal membranes, example synovium, pleura, pericardium. The deposited immune complexes activate the complement cascade, resulting in chemotaxis, recruitment of neutrophils. The antigen-bound IgG bind to the Fc receptors, FcR, on the surface of neutrophils that then release lysosomal enzymes, which damage the local tissues. The site of immune complex deposition determines the clinical features of a type 3 hypersensitivity reaction, example Arthus reaction, vasculitis, glomerulonephritis, synovitis, pneumonitis. Copyright Boss. Uronephritic syndrome, 3/8. C3 deposits in post-streptococcal glomerulonephritis. Immunofluorescence photomicrograph of a renal biopsy specimen, very high magnification, subepithelial deposits of C3 are seen distributed within the capillary loops. The deposits are visible as bright green fluorescence in an irregular granular pattern. This finding is typical of post-streptococcal glomerulonephritis. Source: Figure 3a, in The Role of Nephritis-Associated Plasmin Receptor, NAPIR, in Glomerulonephritis Associated with Streptococcal Infection by Takashi Oda, Nobuyuki Yoshizawa, Kazuo Yamakami et al., Biomed Research International, licensed under CC by 3.0. Uronephritic syndrome, 4/8. T. 1. EY11111111. Copyright. Overlay. Anterior lenticanus in Alport syndrome. Slit lamp photograph of the right eye, mydriatic pupil. The light of the slit lamp produces an optical cross-section of the cornea, left optical cross-section, and the lens, right optical cross-section. Compared to the cornea, the anterior surface of the lens appears conical. Normal physiological shape is indicated by the dashed line. This protrusion of the anterior cortex of the lens is referred to as anterior lenticanus, and it is associated with Alport syndrome. Source: Figure 1 in Clear lens phacoemulsification in the anterior lenticanus due to Alport syndrome, 2 case reports by Gassim Amir Aslanzadeh, Dawoud Garibaghi and Nilufar Nadari, Journal of Medical Case Reports, Biomed Central, licensed under CC by 2.0. Uronephritic syndrome, 5/8. Lupus nephritis. Photomicrograph of a renal cortex biopsy, PA stain, high magnification. The mesangial and endothelial proliferation of the glomerulus has resulted in the dislocation of the capillary lumen and thickening of the capillary wall, creating the appearance of wire loops. This is the typical appearance of proliferative glomerulonephritis. Source: Diffuse Proliferative Lupus Nephritis by Michael Bonard, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephritic syndrome, 6/8. Overlay. Crescent formation in rapidly progressive glomerulonephritis, RPGN, VV. Photomicrograph of kidney biopsy tissue, H&E stain, high magnification, a hypercellular, crescent-shaped zone with an inflammatory infiltrate, yellow overlay, is visible within the glomerulus. Glomerular crescent formation is a characteristic histological finding in RPGN. Source: Figure 1, in ANCA vasculitis and hemophagocytic lymphohistiocytosis following a fecal microbiota transplant by A. M. Lani, A. Bromley, A. Fifima, Hindawi, case reports in rheumatology, licensed under CC by 4.0. Uronephritic syndrome, 6/8. We4. Overlay. Crescent formation in rapidly progressive glomerulonephritis, RPGN, VV. Photomicrograph of kidney biopsy tissue, H&E stain, high magnification, a hypercellular, crescent-shaped zone with an inflammatory infiltrate, yellow overlay, is visible within the glomerulus. Glomerular crescent formation is a characteristic histological finding in RPGN. Source: Figure 1, in ANCA vasculitis and hemophagocytic lymphohistiocytosis following a fecal microbiota transplant by A. M. Lani, A. Bromley, A. Fifima, Hindawi, case reports in rheumatology, licensed under CC by 4.0. Uronephritic syndrome, 7/8. Overlay. Rapidly progressive glomerulonephritis, RPGN, VV. Photomicrograph of a kidney biopsy sample, PA stain, very high magnification, the glomerulus shows a hypercellular, crescent-shaped zone, green overlay, with an inflammatory infiltrate, examples of macrophages indicated by arrowheads. Glomerular crescent formation is a characteristic histological finding in RPGN. Source: Crescentic glomerulonephritis, very high mag JPG by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uronephritic syndrome, 8/8. Overlay. Tram track appearance in membranoproliferative glomerulonephritis VV. Photomicrograph of a kidney biopsy specimen, PA stain, high magnification, the glomerulus shows slightly increased mesangial cellularity, examples indicated by circles, and duplication of the glomerular basement membrane, GBM. The latter displays in the form of a double contour of the GBM, tram track appearance, examples indicated by yellow lines. As a secondary finding, there is an Angiostrongylis larva within the glomerulus, blue overlay. Duplication of the GBM is a typical finding in membranoproliferative glomerulonephritis. Source: Figure 8, Kidney by Laura Rinaldi, Laura Cortez, Leonardo Miomartino et al., BMC Veterinary Research, licensed under CC by 4.0. Modifications: arrow removed. Uronephritic syndrome, 8/8. Overlay S. Tram track appearance in membranoproliferative glomerulonephritis VV. Photomicrograph of a kidney biopsy specimen, PA stain, high magnification, the glomerulus shows slightly increased mesangial cellularity, examples indicated by circles, and duplication of the glomerular basement membrane, GBM. The latter displays in the form of a double contour of the GBM, tram track appearance, examples indicated by yellow lines. As a secondary finding, there is an Angiostrongylis larva within the glomerulus, blue overlay. Duplication of the GBM is a typical finding in membranoproliferative glomerulonephritis. Source: Figure 8, Kidney by Laura Rinaldi, Laura Cortez, Leonardo Miomartino et.al., BMC Veterinary Research, licensed under CC by 4.0. Modifications, arrow removed. Uronephritic syndrome, 1/4. USS P9G0G0 degree % copyright. Acanthocytes VV photomicrograph of a peripheral blood smear, right Guiamsa stain, numerous red blood cells are present. Some of them have irregular protrusions at the surface, yellow overlay. This is a typical finding of acanthocytes. Source, Acanthocytes, Peripheral Blood by Ed Uthman, Flickr, licensed under CC by 2.0. Acanthocyte formation MV. The irregular cell surfaces of the acanthocytes, Mickey Mouse ears, are the result of osmotic stress experienced by the red blood cells inside the tubules. Copyright Emboss. I. Red blood cell cast VV photomicrograph of urine sediment, high magnification, a cast consisting of multiple red blood cells is visible. RBC casts are typically seen in patients with glomerular damage, example glomerulonephritis. Source, copyright IMPP. Uronephritic syndrome, 4/4. Copyright. Overlay. Red blood cell, RBC, casts in urine sediment V. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. X post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, PSGN, is an acute glomerular inflammation that follows infection with nephrogenic strains of streptococci. Although most commonly seen in children following group A streptococcal tonsillopharyngitis, skin infections such as impetigo may also trigger PSGN. Individuals aged 60 years, especially those with diabetes, malignancy, or alcohol dependency, may also be affected. Deposition of immune complexes within the glomerular basement membrane results in complement activation and subsequent damage to the glomeruli. PSGN typically manifests as nephritic syndrome with hematuria, mild proteinuria, edema, and hypertension. Evidence of recent streptococcal infection, example elevated anti-streptolysin O, ASO, and /or anti-DNase B titers, and low complement levels support the diagnosis. Close monitoring and supportive management of edema and hypertension are usually sufficient. Antibiotic therapy is indicated if there is evidence of active gas infection, primarily to minimize the risk of complications and community spread. While most children recover fully, adults are more likely to develop rapidly progressive glomerulonephritis and /or end-stage kidney disease and may require long-term monitoring. WA CE Epidemiology. Scent bimodal age distribution, mostly affects children, between the ages of 3 to 12 years, and patients 60 years of age. The incidence of PSGN has decreased in developed countries due to the systematic use of antibiotics and improved hygienic standards. Epidemiological data refers to the U.S., unless otherwise specified. O. CE. Etiology. Prior infection with group A beta hemolytic streptococci, GAS, site of infection. Copyright in children equals infection of the mouth and pharynx, tonsillitis, pharyngitis. PSGN typically arises 1 to 2 weeks following infection. Equals soft tissue infections, Erysipelas, impetigo PSGN typically arises 4 to 6 weeks following infection. Osteomyelitis degree in adults, the site of infection is usually not the respiratory tract. Infection-associated glomerulonephritis can also occur following other bacterial infections, example with Staphylococcus aureus, Staphylococcus epidermidis, gram-negative bacteria, viral infections, or malaria, and it can also manifest during an acute infection. Infective endocarditis is a common cause of Staphylococcus infection-associated glomerulonephritis, especially amongst individuals who use intravenous drugs. 1, 2. 2 CE. Pathophysiology. Infection with nephritogenic strains of group A beta hemolytic streptococci immune complexes containing the streptococcal antigen deposit within the glomerular basement membrane, likely involves molecular mimicry, complement activation, T consumption of complement factors, destruction of the glomeruli immune complex mediated glomerulonephritis and nephritic syndrome. See glomerular diseases for more information. VA. CE. Clinical features. Approximate 50% of patients remain asymptomatic. Symptoms occur approximately 1 to 6 weeks following an acute infection. Scent nephritic syndrome o hematuria, T or cola-colored urine o hypertension, can lead to headaches o edema, prominent facial edema, copyright oliguria plus influenza-like symptoms 1e flank pain. Back collapse fine text outline. Diagnostics. Suspect PSGN in individuals with features of nephritic syndrome and a recent history of gas infection. 1. Initial evaluation MI425. Asterisk urinalysis with microscopy, nephritic sediment o hematuria with RBC casts o proteinuria o pyuria scent quantification of proteinuria, typically shows non-nephrotic range proteinuria, A2 plus BMP may reveal, 6107 Bun, T creatinine electrolyte abnormalities CBC, may show normocytic, normochromic anemia 7 plus C3 complement, C4 complement levels, classically shows 4 C3 complement with normal C4 complement SIL8, evidence of preceding gas infection. Scent anti-streptococcal antibody titers OT-ASO, F antidinase B antibodies, TT antihyaluronidase antibodies isolation of group A beta hemolytic streptococci degree equals pharyngitis, rapid strep test, throat culture equals skin lesions, wound cultures. Copyright PSGN typically occurs following a gas infection rather than during an active infection. Obtain appropriate diagnostic studies to isolate group A beta hemolytic streptococci only if active infection is suspected. 1. Additional studies 1. Renal ultrasound, 11. Indications, may be obtained during a diagnostic workup of hematuria scent findings, typically normal, may show nonspecific increased echogenicity of the renal cortex. Renal biopsy, 121I2. Plus indications, not routinely performed. Copyright signs of rapidly progressive glomerulonephritis. Copyright atypical presentation 1 plus supportive findings, proliferative glomerulopathy with immune complex deposits 1%, 3 O-light microscopy, enlarged and hypercellular glomeruli, O immunofluorescent microscopy, granular deposits in the glomerular mesangium and capillaries %, 4LL131L2 equals consisting of IgG, IgM, C3 complement 3 equals lumpy bumpy appearance, also called a starry sky. Appearance, AHN4 copyright electron microscopy, immune complexes between the epithelial cell layer and the glomerular basement membrane, referred to as subepithelial humps, 1312. DS. Differential diagnoses. C. Diseases associated with nephritic syndrome. And AO. Back collapse fine text outline. Treatment. Most cases of PSGN are self-limiting and complications of volume overload are managed with supportive treatment. Supportive care, 1L2. Management of edema and volume overload. Plus low-sodium diet. Scent indicated for hypertension refractory to management of edema and volume overload. Scent preferred agents include, copyright calcium channel blockers, example nifedipine, copyright ACE inhibitors or ARBs equals uncertain benefit, given the self-limited nature of PSGN-L2 equals avoid in patients with rapidly progressive renal dysfunction. 1. Copyright avoid ACE inhibitors and ARBs in patients with rapidly worsening renal function and or sudden onset of nephrotic range proteinuria, as these medications can exacerbate AKI and hyperkalemia. 12. Antibiotic therapy. Antibiotics do not affect the course of PSGN but should be administered in individuals with active gas infection to prevent complications, example abscess, rheumatic fever, and community outbreak of nephrogenic strains of S. pyogenes. 16. Indication, evidence of active infection, example positive cultures for gas, to prevent 0E regimens, should be based on the site of infection degree gas tonsillopharyngitis. Initiate recommended antibiotic regimens for acute gas pharyngitis. O. Skin and soft tissue infections, example impetigo. Begin empiric antibiotic therapy for skin and soft tissue infections. Complications. Complications are more common in adults, acute renal failure, rapidly progressive glomerulonephritis, nephrotic syndrome later in the course of the disease. We list the most important complications. The selection is not exhaustive. At shared note. Prognosis. E-recovery usually occurs within 6 to 8 weeks. O. In children, restitution of kidney function in 90% of cases. Degree in some cases, urinalysis may remain abnormal for extended periods. In adults, about 50% of patients suffer from persistently reduced renal function. O. Your notes to shared note. Tips and links. Sources. Last updated November 18, 2022. Al. Outline. Post-streptococcal glomerulonephritis, 1/4. F. Wisplinghoff Laboratories. Overlay. Red blood cell, RBC, casts in urine sediment VV. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Post-streptococcal glomerulonephritis, 2/4. A equals, O. 4 EEO asterisk AEopia. Nat. OG OSNE/. Overlay. Post-infectious glomerulonephritis VV. Microscopic image of a kidney biopsy, PA stain, high magnification. A renal corpuscle surrounded by numerous tubules can be seen in the center of the image. Because the renal corpuscle is markedly enlarged, the space between the glomerular capillaries and the parietal layer of the Bowman capsule, black dashed outline, is narrowed. Within the glomerulus, there is hypercellularity due to proliferation of endothelial cells, yellow arrowheads, and mesangial cells, black arrowheads. Inflammatory infiltrate, predominantly neutrophils, blue arrowheads, and monocytes, white arrowheads, is also present. As a result, the lumina of the capillaries are not clearly identifiable. This is the histopathologic appearance of post-infectious glomerulonephritis. Source: Post-infectious glomerulonephritis, Very High Mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Post-streptococcal glomerulonephritis, 3/4. Acute post-streptococcal glomerulonephritis, APSGN. Fluorescence microscopy, immunofluorescence staining for C3, high magnification. Granular deposits of C3 are visible, resulting in a starry sky pattern. Euro post-streptococcal glomerulonephritis, 4/4. Overlay. Post-infectious glomerulonephritis, PIGN, VV. Transmission electron micrograph, TEM, of renal tissue from a patient with non-HPV-associated PIGN. A glomerular capillary containing a red blood cell, red overlay, and an epithelial foot process of a renal podocyte can be seen, green overlay. Multiple hump-shaped electron-dense deposits, arrows, are also apparent. These subepithelial immune complex deposits may be present in PIGN. Blue overlay, nucleus of endothelial cell source, Fig 3, in HPV-associated post-infectious acute glomerulonephritis, a report of 10 cases by Zhang Y, Li J, Peng Wetal, PLOS1, licensed under CC by 4.0. Modifications, image cropped. Euro post-streptococcal glomerulonephritis, 4/4. Overlay. Post-infectious glomerulonephritis, PIGN, VV. Transmission electron micrograph, TEM, of renal tissue from a patient with non-HPV-associated PIGN. A glomerular capillary containing a red blood cell, red overlay, and an epithelial foot process of a renal podocyte can be seen, green overlay. Multiple hump-shaped electron-dense deposits, arrows, are also apparent. These subepithelial immune complex deposits may be present in PIGN. Blue overlay, nucleus of endothelial cell source, Fig 3, in HPV-associated post-infectious acute glomerulonephritis, a report of 10 cases by Zhang Y, Li J, Peng Wetal, PLOS1, licensed under CC by 4.0. Modifications, image cropped. IgA nephropathy. IgA nephropathy, Berger disease, is the most common primary glomerulonephritis worldwide. It most frequently affects males in the second to third decades of life. Clinical manifestations are usually triggered by upper respiratory tract or gastrointestinal infections and include gross hematuria and flank pain. In some cases, it may present as rapidly progressive glomerulonephritis, RPGN. Urinalysis of asymptomatic patients often shows persistent microhematuria and minor proteinuria, while more severe cases may manifest with recurrent episodes of nephritic syndrome. A kidney biopsy is indicated in patients with signs of severe or progressive disease to make a definitive diagnosis. Treatment consists of measures to slow the progression of the disease, example ACE inhibitors, as well as immunosuppressive therapy in more severe cases. Even with the appropriate treatment, up to 50% of patients progress to end-stage renal disease within 20 to 25 years. Z*CE. Epidemiology. IgA nephropathy is the most common primary glomerulonephritis in adults. 0. Peak incidence, second to third decades of life, 21 copyright sex, $7, 2:1, I3 ethnicity, more common in the Asian population, worldwide. 4. Epidemiological data refers to the U.S., unless otherwise specified. WA. And. Pathophysiology. The cause is still not entirely understood. Most likely mechanism, an increased number of defective, circulating IgA antibodies are synthesized, often triggered by mucosal infections, i.e., upper respiratory tract and gastrointestinal infections, IgA antibodies form immune complexes that deposit in the renal mesangium mesangial cell and complement system activation. Glomerulonephritis, type 3 hypersensitivity reaction, 5. VA. OSO. Clinical features. The course of the disease is highly variable and can manifest in the following forms: asymptomatic recurring episodes of O gross or microscopic hematuria, O flank pain, O low-grade fever, O and/or nephritic syndrome, including hypertension, O usually during or immediately following a respiratory or gastrointestinal infection. I. 5 * can progress to RPGN and/or nephrotic syndrome. IgA nephropathy and IgA vasculitis are both IgA-mediated vasculitides triggered by a mucosal infection. IgA vasculitis most commonly occurs in children. References: SII 7 IISI 91 L10111. 005. Diagnostics. Diagnosis is based on clinical presentation and laboratory results. In some cases, renal biopsy may be indicated to confirm the diagnosis. Urinalysis. Copyright signs of nephritic sediment, including persistent microhematuria and possibly minor proteinuria. Copyright episodic flare UPS of gross hematuria in 50% of patients. 7. In rare cases, nephrotic sediment. Laboratory tests. Back collapse. Fine text outline. References: 6 LL7 IELI 9 ITV 1111. VAOS. Diagnostics. Diagnosis is based on clinical presentation and laboratory results. In some cases, renal biopsy may be indicated to confirm the diagnosis. Scent urinalysis. Copyright signs of nephritic sediment, including persistent microhematuria and possibly minor proteinuria. Copyright episodic flare UPS of gross hematuria in 50% of patients. M7E. In rare cases, nephrotic sediment. Scent laboratory tests. O serum IgA level is elevated in 50% of patients. Copyright complement levels, example C3 level, are generally normal. 521. Scent renal biopsy. O usually only indicated if there are signs of severe or progressive disease, including urinary protein 0.5 to 1 g/24 H = 1, serum creatinine = hypertension. Copyright findings = light microscopy, mesangial proliferation = immunofluorescent microscopy, mesangial IgA deposits = electron microscopy, mesangial immune complex deposits. B. The renal manifestation of IgA vasculitis is pathologically the same as IgA nephropathy. Differential diagnoses. Scent post-streptococcal glomerulonephritis. Copyright associated with low complement levels. Copyright typically occurs 10 to 20 days following an infection. Lupus nephritis. Membranoproliferative glomerulonephritis. The differential diagnoses listed here are not exhaustive. WAY. OE. Treatment. Patients with isolated hematuria. Copyright regularly monitor kidney function and initiate treatment if disease progresses, example occurrence of proteinuria. Symptoms resolve spontaneously in 30% of patients. Patients with proteinuria or hypertension, ACE inhibitors/angiotensin II receptor blockers. FA. 2 OE. Sources. Last updated July 21, 2023. Back collapse. Fine text outline. IgA nephropathy, 1/1. Overlay. IgA nephropathy VV. Photomicrograph of kidney tissue, PA stain. A glomerula surrounded by numerous tubules is visible in the center of each image. There is a proliferation of mesangial cells, examples marked by yellow circles, with extracellular matrix deposition within the glomeruli. In IgA nephropathy, these changes can range from focal segmental, examples indicated by black arrows, to diffuse, examples indicated by yellow arrowheads. This is the characteristic histopathologic appearance of IgA nephropathy. Blue outlines, glomerular capillaries source, copyright IMPP. IgA nephropathy, 1/1. Overlay. IgA nephropathy VV. Photomicrograph of kidney tissue, PA stain. A glomerulus surrounded by numerous tubules is visible in the center of each image. There is a proliferation of mesangial cells, examples marked by yellow circles, with extracellular matrix deposition within the glomeruli. In IgA nephropathy, these changes can range from focal segmental, examples indicated by black arrows, to diffuse, examples indicated by yellow arrowheads. This is the characteristic histopathologic appearance of IgA nephropathy. Blue outlines, glomerular capillaries source, copyright IMPP. X. Hemolytic uremic syndrome. Hemolytic uremic syndrome, HUS, is a thrombotic microangiopathy in which microthrombi, consisting primarily of platelets, form and occlude the arterioles and capillaries. These occlusions result in the simultaneous occurrence of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, AKI. HUS predominantly affects children and is caused by bacterial toxins, most commonly the Shiga-like toxin of enterohemorrhagic Escherichia coli, E. coli, 0157H7. If there is a strong suspicion of HUS based on clinical presentation and initial laboratory tests, treatment should begin immediately, as the condition may result in renal failure. Patients receive symptomatic treatment for renal symptoms, anemia, and complications affecting other organs, such as the brain and GL tract. Thrombotic thrombocytopenic purpura, TTP, the other main type of thrombotic angiopathy, is discussed in the respective article. VACE. Epidemiology. Mainly children. Epidemiological data refers to the U.S., unless otherwise specified. OE. Etiology. Plus bacterial exotoxins 2. O. Shiga-like toxin, virotoxin, from enterohemorrhagic E. coli, EHEC, strain 0157H7 equals usually transmitted via contaminated foods, example undercooked beef or raw leafy vegetables, copyright Shiga toxin produced by Shigella dysenteriae sent Streptococcus pneumoniae infection sent atypical hemolytic uremic syndrome, complement dysregulation, hereditary or acquired, accounts for approximate 5% of HUS cases with non-infectious etiologies, referred to as atypical HUS, AHUS. 83. Approximate 15% of children infected with E. coli 0157H7 will go on to develop HUS. OOE. Pathophysiology. HUS is a thrombotic microangiopathy, a condition characterized by the formation of microthrombi occluding the microvasculature. The other main thrombotic microangiopathy is thrombotic thrombocytopenic purpura, TTP. The two conditions have some pathophysiology and clinical findings in common, but different etiologies. HUS is caused by bacterial toxins. 4. 1. Infection with enterohemorrhagic E. coli, EHEC, or another causative organism. 2. Mucosal inflammation facilitates bacterial toxins entering systemic circulation. 3. Toxins cause endothelial cell damage, especially in the glomerulus. 4. Damaged endothelial cells secrete cytokines that promote vasoconstriction and platelet microthrombus formation at the site of damage, intravascular coagulopathy, thrombocytopenia, consumption of platelets. 5. RBCs are mechanically destroyed as they pass through the platelet microthrombi occluding small blood vessels, i.e., arterioles, capillaries, hemolysis. Schistocytes, and end organ ischemia and damage, especially in the kidneys. Decreased glomerular filtration rate, GFR. At E. coli 0157H7 infection Shiga-like toxin in systemic circulation toxin-mediated endothelial injury microthrombus formation blockage of small vessels RBC fragmentation, hemolysis, and end organ damage. WY. OE. Clinical features. A diarrheal illness, usually bloody, for the past 5 to 10 days precedes the onset of HUS symptoms in many children. The triad of clinical findings occurring in HUS consists of 4% thrombocytopenia o petechiae, purpura. Back collapse. Fine text outline. Cent thrombocytopenia o petechiae, purpura e mucosal bleeding o prolonged bleeding after minor cuts ** microangiopathic hemolytic anemia. O fatigue, dyspnea, and pallor. Degree jaundice. Cent impaired renal function o hematuria, proteinuria. Copyright oliguria, anuria. And the typical HUS patient is a preschooler who has had a diarrheal illness for the past 5 to 10 days and presents with petechiae, jaundice, and oliguria. And F. Diagnostics. Cent hematology. Copyright hemolytic markers. Hemoglobin. Haptoglobin equals 7. Indirect bilirubin. T reticulocytes. 7 LDH. T schistocytes on blood smear, up to 10% of RBCs. A. Copyright coagulation profile. Platelets normal/slightly elevated prothrombin time, PT, and activated partial thromboplastin time, APTT. In contrast to DIC, see differential diagnoses below. Normal/slightly elevated fibrin degradation products and D-dimer levels. OTWBC count. I. Copyright negative Coombs test * serum. Chemistry, T-bun and F. Creatinine, impaired renal function, Cent urinalysis, hematuria, proteinuria. Dollar, %. Differential diagnoses. HUS. Cent endothelial cell dysfunction due to bacterial toxins. Pathophysiology. Toddler or preschooler with history of diarrheal illness presents with typical presentation. Petechiae, jaundice, and oliguria. Back. Plus ADAMTS 13 deficiency. Previously healthy adult, sometimes associated with triggers, example infection, surgery, pregnancy, presents with mental status changes, fever, petechiae, fatigue, and pallor. Is of disseminated intravascular coagulation, DIC. Systemic coagulation activation. Platelet and coagulation factor consumption, mixed disorder. Patient with a history of serious underlying illness, example sepsis, trauma, malignancy, presents with thrombosis. Immune thrombocytopenic AE purpura, ITP, A. Plus adhesion disorder. Facient platelet antibodies, and GPIB4X GPLLB/ILA GPLLB/ILA, * autosomal recessive. Glanzmann thrombasthenia. Plus aggregation disorder, deficient platelet GPILB/ILA autosomal recessive. Asymptomatic or presenting with petechiae, purpura, epistaxis, menorrhagia, gingival bleeding, embolism, organ dysfunction, and / bleeding. ADS/ARS collapse. A. Fine text. A. Outline. Diff-EL diagnosis of P. disorder. Immune. Disseminated intravascular. Bernard-Soulier HUS TTP coagulation, DIC, thrombocytopenic syndrome. Glanzmann thrombasthenia equals AE purpura, ITP. Plus adhesion * systemic coagulation. AU disorder, plus aggregation disorder, Cent endothelial cell activation. Cent antiplatelet equals Senate deficient platelet GPILB. Pathophysiology dysfunction due to plus ADAMTS 13 deficiency * platelet and coagulation antibodies, anti-GPIBAX/ILA bacterial toxins factor consumption, mixed GPLLB/ILA. Autosomal * autosomal recessive disorder, equals recessive. * patient with a history of * toddler or previously healthy adult, NFTFF serious underlying illness preschooler with sometimes associated with example sepsis, trauma, history of diarrheal triggers, example infection, 4R3 malignancy, asymptomatic or presenting with petechiae, purpura, epistaxis, typical presentation illness surgery, pregnancy, EEP poorly equals asterisk presents with thrombosis, menorrhagia, gingival bleeding presents with asterisk presents with mental status. Underscore embolism, organ petechiae, jaundice, changes, fever, petechiae. Dysfunction, and slash or an oliguria fatigue, and pallor. Bleeding. Asterisk giant platelets sent normal platelets sent abnormal results on. Plus schistocytes sent plus slash schistocytes, peripheral smear morphology abnormal platelet aggregation J platelets, EJ platelets Ristocedin testing confirm the cofactor assay diagnosis. PT, INR, and a PTT equals asterisk normal slash increased sent increased asterisk normal. D-dimer, fibrin degradation asterisk normal slash increased sent increased normal products. Other platelet disorders. Von Willebrand disease sent acquired disorders of platelet function, example drugs such as aspirin, NSAIDs, uremia, paraproteins, see also thrombocytopenia and heparin-induced thrombocytopenia. The differential diagnoses listed here are not exhaustive. Treatment. Send supportive care to. Copyright avoid antibiotics and antimotility agents, may increase the likelihood of HUS in suspected infection with EHEC. O monitor and correct. Equals fluid status abnormalities, for more information, see clinical assessment of volume status, equals electrolyte disturbances, for more information, see electrolyte metabolism, equals acid-base disorders equals blood pressure, due to hypertension or septic shock, equals RBC transfusions 1. Copyright antiepileptic drugs, example diazepam, phenytoin, in patients with seizures sent dialysis, as indicated for ACI up to 50% of HUS patients require dialysis. Sent plasma exchange therapy, only in refractory cases a sent eculizumab. O effective for the treatment of AHUS, registered. O may be beneficial in HUS with neurological symptoms, 6. At, post-diarrheal HUS is a nationally notifiable condition. 7. Copyright platelet transfusions should be administered with caution unless patients are bleeding or require an invasive procedure. Some studies suggest that they can exacerbate microangiopathy. OON. Complications. HUS can result in microthrombus formation and complications in various organs. Asterisk CNS. O seizures oparesis. Back collapse fine text outline. Equals electrolyte disturbances, for more information, see electrolyte metabolism, equals acid-base disorders equals blood pressure, due to hypertension or septic shock, RBC transfusions copyright antiepileptic drugs, example diazepam, phenytoin, in patients with seizures sent dialysis, as indicated for ACI up to 50% of HUS patients require dialysis. Plus plasma exchange therapy, only in refractory cases eculizumab copyright effective for the treatment of AHUS, 5 copyright may be beneficial in HUS with neurological symptoms, 6. Platelet transfusions should be administered with caution unless patients are bleeding or require an invasive procedure. Some studies suggest that they can. Copyright post-diarrheal HUS is a nationally notifiable condition. V7. Exacerbate microangiopathy. Complications. HUS can result in microthrombus formation and complications in various organs, CNS1. O seizures, O paresis, O stroke, degree, coma, scent, GL tract, EO hemorrhagic colitis, copyright bowel necrosis, perforation, stricture, copyright peritonitis, copyright intussusception, scent heart, ischemia and fluid overload, scent pancreas, transient or permanent diabetes mellitus, scent liver, hepatomegaly, transaminase elevations, asterisk kidney, O hypertension, copyright chronic kidney disease, CKD, O end-stage renal disease, ESRD. We list the most important complications. The selection is not exhaustive. 7 VEAO. Prognosis. The prognosis depends primarily on prompt initiation of treatment. Timely treatment can prevent acute complications, AKI, coma, and death, as well as progression to chronic renal failure. Sent with treatment, the mortality rate of HUS is low. Your Note 8 shared notes. Sources. Last updated November 18, 2022. SJ equals A. Back collapse, find text outline. Urohemolytic uremic syndrome, 1/1. Hemolytic uremic syndrome, HUS, thrombotic thrombocytopenic purpura, TTP. Pallor, jaundice. 6. Neurological symptoms, example headache, confusion, seizure, IP mucosal bleeding. 4. Fever. 4. Petechiae, purpura, bruises at 9 LTYP, XESYTR. ESFALSENE history of -- plus *, asterisk /YWWALE bloody diarrhea due to J/S, 7 / need, equals ECOL strain. O157H17PE, equals N oliguria, hematuria OE / produces Shiga toxin, / KS Lee /. Laboratory findings HEANT. AOEEE hemolytic anemia VE thrombocytopenia weld Wes ET creatinine YEE schistocytes on blood smear ETTP, ADAMTS 13 activity. Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura VV. Copyright emboss. Equals hemolytic uremic syndrome, 1/4. Sane. Phi copyright OO on EI Wisplinghoff Laboratories. Copyright overlay. Schistocytes VV photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Equals hemolytic uremic syndrome, 1/4. N. Wisplinghoff Lab. SW overlay. Schistocytes VV. Photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Equals hemolytic uremic syndrome, 2/4. Schistocytes in hemolytic uremic syndrome VV. Photomicrographs of a peripheral blood smear erythrocytes with a convex and a concave side can be seen among the normal erythrocytes. These fragmented erythrocytes are known as schistocytes, black circles. Schistocytes are a diagnostic finding of hemolytic uremic syndrome, US. They may also be caused by other forms of microangiopathic hemolytic anemia or mechanical damage to erythrocytes. Source: Copyright IMPP. Ovary I. V. Graph Foporifer, Blug Tithro Ea and S, SCNJTicide, Ithalco, Arrow. Be seen through E, Verla Ajora 9 Typic Diagnostic Find, GI Hema. Order on the equals hemolytic uremic syndrome, 4/4. 10% 7 Q0 600,096,0008. Overlay. Schistocytes VV. Photomicrograph of a peripheral blood smear fragmented erythrocytes, which are convex on one side, examples indicated by blue lines, and concave on the other, examples indicated by yellow lines, can be seen among the normal erythrocytes. These fragmented erythrocytes are referred to as schistocytes. Schistocytes are a diagnostic finding in patients with microangiopathic hemolytic anemias and those with mechanical damage to erythrocytes, example from artificial heart valves. Source: Schistocytes by Professor Osiro Haber, Wikimedia Commons, licensed under CC 1.0. Modifications: cropped the image as there was some bad quality scale in the right lower edge. Equals hemolytic uremic syndrome, 4/4. 1 OPSO 09% F6,000K. Overlay. Schistocytes VV. Photomicrograph of a peripheral blood smear fragmented erythrocytes, which are convex on one side, examples indicated by blue lines, and concave on the other, examples indicated by yellow lines, can be seen among the normal erythrocytes. These fragmented erythrocytes are referred to as schistocytes. Schistocytes are a diagnostic finding in patients with microangiopathic hemolytic anemias and those with mechanical damage to erythrocytes, example from artificial heart valves. Source: Schistocytes by Professor Osiro Haber, Wikimedia Commons, licensed under CC 1.0. Modifications: cropped the image as there was some bad quality scale in the right lower edge. Hemolytic uremic syndrome, 1/1, EUVE. He. F. Nephrosclerosis following hemolytic uremic syndrome, US, VV. Photomicrograph of renal tissue, HNE stain, high magnification. The renal corpuscle in the center of the image is surrounded by numerous atrophic tubules, examples indicated by blue overlay, and partly occluded vessels with eosinophil hyaline material, fibrin and platelet aggregates, indicated by green overlay. Also, interstitial fibrosis, examples indicated by red overlay, and interstitial edema, examples indicated by yellow overlay, can be seen within the surrounding tissue. The amount of interstitial fibrosis indicates nephrosclerosis. Source: Copyright IMPP. Hemolytic uremic syndrome, 1/1. Nephrosclerosis following hemolytic uremic syndrome, US, VV. Photomicrograph of renal tissue, HNE stain, high magnification. The renal corpuscle in the center of the image is surrounded by numerous atrophic tubules, examples indicated by blue overlay, and partly occluded vessels with eosinophil hyaline material, fibrin and platelet aggregates, indicated by green overlay. Also, interstitial fibrosis, examples indicated by red overlay, and interstitial edema, examples indicated by yellow overlay, can be seen within the surrounding tissue. The amount of interstitial fibrosis indicates nephrosclerosis. Source: Copyright IMPP. X. Nephroblastoma. Nephroblastoma, Wilms tumor, is the most common renal malignancy in children, typically affecting children between 2 and 5 years of age. A minority of cases are associated with specific syndromes, example WAGR, Beckwith-Wiedemann, and gene mutations, example WT1. Nephroblastoma is typically an incidental finding that manifests as a large abdominal mass. Other signs and symptoms may occur, such as hematuria and abdominal pain, especially in tumors that are large, ruptured, or metastasized. Treatment consists of tumor resection and chemotherapy for all stages, except for very low-risk tumors, while radiation is predominantly used in advanced disease. OOOE. Epidemiology. Plus peak incidence, between 2 and 5 years ***. Most common malignant neoplasm of the kidney in children. References. Epidemiological data refers to the U.S., unless otherwise specified. VA and etiology. The exact etiology of nephroblastoma remains unknown, but it is associated with several genetic mutations and syndromes. Genetic predisposition 2-3. Gene mutations have been found in children both with and without genetic syndromes who have nephroblastoma, Wilms tumor. Associated with loss of function mutations of tumor suppressor genes on chromosome 11O. The WT1, Wilms tumor 1, gene is the most important nephroblastoma tumor gene, mutated in 10 to 20% of cases. Copyright WT2, Wilms tumor 2, gene 1-4, associated syndromes, 1/5. CENT WAGR syndrome, deletion of the 11p13 band leads to the deletion of the WT1 gene and other genes, such as PAX6. 6 Nephroblastoma. Copyright aniridia. Copyright genitourinary anomalies equals pseudohermaphroditism, undescended testes in males, due to gonadal dysgenesis, equals early onset nephrotic syndrome. A range of intellectual disability. Dennis-Drash syndrome, point mutation in WT1 gene, which encodes a zinc finger transcription factor M7. Nephroblastoma. Pseudohermaphroditism, undescended testes in males, due to gonadal dysgenesis. Copyright early onset nephrotic syndrome caused by diffuse mesangial sclerosis. CENT Beckwith-Wiedemann syndrome, mutations of the WT2 gene. CE, WAGR syndrome consists of Wilms tumor, aniridia, genitourinary anomalies, and range of intellectual disability. Copyright Dennis-Drash syndrome is a mild form of WAGR without aniridia or intellectual disability. 47 CE. Clinical features. Abdominal symptoms. Palpable abdominal mass, often found incidentally. Copyright non-tender. Copyright unilateral and large but not crossing midline. Copyright smooth and firm abdominal pain, 40% of cases. Other signs and symptoms. Back collapse. Fine text outline. Other signs and symptoms. Hematuria, 25% of cases. Hypertension, 25% of cases. Asterisk in cases of subcapsular hemorrhage. Anemia. Copyright possibly fever. Asterisk symptoms caused by metastatic spread, example pulmonary symptoms. Nephroblastoma should be suspected in a toddler with a non-tender abdominal mass, especially if it is firm, smooth, and associated with hematuria and/or hypertension. Copyright careless palpation of a nephroblastoma can result in rupture of the renal capsule and tumor spillage. OS. FOIEEE. Stages. National Wilms Tumor Study, NWTS, System. 8. Tumor stage location. Tumor spread surgery. 1. Untateral * limited to the kidney * no renal sinus vessel involvement. * extends beyond kidney * complete resection with no tumor beyond the excision margins. Copyright unilateral OE renal capsule. Copyright soft tissue of the renal sinus. Copyright blood vessels beyond the renal parenchyma. * confined to the abdomen. IL * unilateral * dissemination in abdomen, example regional lymph nodes, peritoneal involvement. 1 * incomplete resection with residual tumor remaining postoperatively, example not resectable due to VV. Unilateral * hematogenous metastasis, example lung, liver, bone, brain, infiltration into vital structures, asterisk unilateral asterisk distant lymph nodes involvement, outside of abdomen. VV asterisk bilateral asterisk both kidneys are affected. Yo. OOMO. Diagnostics. Scent urinalysis, hematuria may be present. Imaging copyright ultrasound, best initial test, hypervascular tumor mostly uniform echogenicity with hypojoy areas of necrosis. Copyright abdominal CT/MRI equals to assess extent of involvement equals surgical planning. Copyright CT thorax/CXR equals to detect metastases equals staging. Copyright biopsy is usually reserved for assessing nodules that are suspected metastases, as tumor capsule rupture and spillage results in more advanced staging and intensive treatment. Back collapse. Find text outline. Pathology. Overview. Nephroblastoma consists of embryonic glomerular structures. May include cysts, hemorrhage, or necrosis. Scent typically has a pseudocapsule histology. Scent classic type, consists of three cell types: AAAO epithelial cells, i.e., glomeruli, and tubules. Copyright stromal cells. O undifferentiated blast M. cells of metanephric origin plus anaplastic type. 1. Copyright contains multipolar polypoid mitotic figures. O marked hyperchromasia of nuclei. A shared knot. Differential diagnoses. Neuroblastoma. 9. Clinical findings, example fever, weight loss, CT/MRI findings, example calcificati midline, 1 to 123 mIBG scan catecholamine metabolites in urine, VMA, HVA. Other renal tumors. Scent clear cell sarcoma, scent rhabdoid tumor, congenital mesoblastic nephroma, renal cell carcinoma, scent renal medullary carcinoma. The differential diagnoses listed here are not exhaustive. OOSE10DA, 5 shared notes. Treatment. 7 of NEP treatment: renal parenchymal sparing resection. Asterisk no surgery, nephrectomy. Degree yes, preoperative chemotherapy. Asterisk no chemotherapy, doxorubicin. Asterisk no dactinomycin and vincristine. Degree yes, 4. Radiation no. OCOZWVNA back collapse. Stages and IL. Nephroblastoma, neuroblastoma less common, asterisk more common, less common, asterisk more common, negative, asterisk positive, 90% of cases, negative, asterisk positive, 70 to 90% of cases. Ding to stage. Stages 3 and 4. Stage V, bilateral, degree yes, asterisk no, asterisk yes, yes. Asterisk possible, asterisk yes. A. Find text outline. WCE. Differential diagnoses. Neuroblastoma A-Tinks and A9. Nephroblastoma, neuroblastoma clinical findings, example fever, weight loss, asterisk less common, asterisk more common, CT/MRI findings, example calcificati midline crossing, asterisk less common, asterisk more common, 1 to 123 mIBG scan, asterisk negative, asterisk positive, 90% of cases, catecholamine metabolites in urine, VMA, HVA, plus negative, asterisk positive, 70 to 90% of cases. Other renal tumors. Scent clear cell sarcoma, rhabdoid tumor, asterisk congenital mesoblastic nephroma, renal cell carcinoma, renal medullary carcinoma. The differential diagnoses listed here are not exhaustive. WAFOI or treatment. TI of nephrobuilding to stage. Treatment stages and 2 stages IL and 4. Stage V, bilateral, renal PAR sparing no, degree yes, surgery, nephrectomy yes, asterisk no, preoperative chemotherapy, asterisk no, asterisk yes, chemotherapy, doxorubicin, asterisk no, yes, dactinomycin and vincristine, asterisk yes, J, radiation, asterisk no, asterisk possible, asterisk yes. GVOOIO. Prognosis. Asterisk good prognosis, survival rates are 90%. 101. The majority of tumor recurrences happen within 2 years of treatment. OORO prevention. Regular screening of children with associated syndromes, example abdominal ultrasound every 3 months until the age of 8. WAOOB. Sources. Last updated September 6, 2022. Back collapse. Find text O outline. Overlay. Nephroblastoma. MRI abdomen, T2 weighted with fat saturation, coronal plane, of a 3-year-old child. A large heterogeneous but relatively well circumscribed solid mass is centered within the lower pole of the left kidney. Normal renal tissue is seen cranial to the mass. The hypointense areas of the mass suggest soft tissue, whereas the areas of hyperintensity suggest hemorrhage or necrosis. Biopsy confirmed the diagnosis of nephroblastoma, Wilms tumor, the most common type of pediatric renal cancer, with a peak incidence at 3 to 4 years of age. Source: Copyright IMPP. Copyright. Overlay. Nephroblastoma. MRI abdomen, T2 weighted with fat saturation, coronal plane, of a 3-year-old child. A large heterogeneous but relatively well circumscribed solid mass is centered within the lower pole of the left kidney. Normal renal tissue is seen cranial to the mass. The hypointense areas of the mass suggest soft tissue, whereas the areas of hyperintensity suggest hemorrhage or necrosis. Biopsy confirmed the diagnosis of nephroblastoma, Wilms tumor, the most common type of pediatric renal cancer, with a peak incidence at 3 to 4 years of age. Source: Copyright IMPP. Overlay. Nephroblastoma VV. MRI abdomen, T2 weighted, transverse view, of a 3-year-old child. A large heterogeneous well-defined mass, green overlay, is demonstrated originating from the left kidney, K. The mass displaces the kidney ventrally. The heterogeneous appearance of the mass is a result of the tumor consisting of various types of tissue and areas of calcification, necrosis, and hemorrhage. A biopsy confirmed the diagnosis of nephroblastoma, Wilms tumor. The main differential diagnosis for this would be neuroblastoma, a type of tumor arising from the adrenal gland. These tumors are usually poorly circumscribed in comparison to nephroblastomas, as they are not encased by the renal capsule. Neuroblastomas also normally affect those aged 2 and under. Source: Copyright IMPP. Overlay. Nephroblastoma VV. MRI abdomen, T2 weighted, transverse view, of a 3-year-old child. A large heterogeneous well-defined mass, green overlay, is demonstrated originating from the left kidney, K. The mass displaces the kidney ventrally. The heterogeneous appearance of the mass is a result of the tumor consisting of various types of tissue and areas of calcification, necrosis, and hemorrhage. A biopsy confirmed the diagnosis of nephroblastoma, Wilms tumor. The main differential diagnosis for this would be neuroblastoma, a type of tumor arising from the adrenal gland. These tumors are usually poorly circumscribed in comparison to nephroblastomas, as they are not encased by the renal capsule. Neuroblastomas also normally affect those aged 2 and under. Source: Copyright IMPP. Nephroblastoma, 1/1. Overlay. Wilms tumor, nephroblastoma, v. Photomicrograph of kidney tumor, H&E stain, medium magnification. A tumor composed of 3 components is seen, triphasic tumor pattern 1. Sheets of small tumor cells with hyperchromatic monomorphous nuclei, blast M-all component, green overlay, 2. Glomerulus-like round structures, epithelial component, can comprise undifferentiated and well-differentiated tubuli, examples indicated by yellow overlay, 3. Ribbons of connective tissue comprised of spindly cells, Stromal component, red overlay. In the kidneys, this triphasic appearance is diagnostic of Wilms tumor, nephroblastoma. Source: Wilms tumor, nephroblastoma, by Ed Uthman, Flickr, licensed under CC by 2.0. Nephroblastoma, 1/1. Wilms tumor, nephroblastoma, VV. Photomicrograph of kidney tumor, H&E stain, medium magnification. A tumor composed of 3 components is seen, triphasic tumor pattern 1. Sheets of small tumor cells with hyperchromatic monomorphous nuclei, blast ML component, green overlay, 2. Glomerulus-like round structures, epithelial component, can comprise undifferentiated and well-differentiated tubuli, examples indicated by yellow overlay, 3. Ribbons of connective tissue comprised of spindly cells, stromal component, red overlay. In the kidneys, this triphasic appearance is diagnostic of Wilms tumor, nephroblastoma.